Yeah.
So that means like we will be utilizing the time effectively.
And then, I mean, that'll take a lot of time.
Yeah.
The FAQs will be well used as well. Did we put hydrochloroquine in our FAQs? I think we did.
Yeah.
You updated
the same
that?
slides are there. There are no new evidence, so I have kept the April recommendations like as such, because like there are no new evidence stating any beneficial effect of chloroquine. Those are there in the FAQ number 1, in the like general FAQs, the general topics, the last slides of FAQ 1. சிவகுமார் சார் என்ன சார் கனெக்ட் ஆயிருக்கீங்க?
Good evening, everyone. Dr. Ramdas, sir, or IMA treasurer, to start with the prayer, IMA prayer.
Okay, good evening, friends. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. I am a prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Thank you.
I take this privilege to welcome Dr. Dan as well as Mannin Maindan A.S. Valan from Center for Disease Control and Prevention of India. At the same time, this is the second time we are conducting the combined meeting of Kanyakumari district. Welcome all the IMA president and office bearers of Kanyakumari district, and our chief guest of this evening is Dr. Vijay Kumar as well as Dr. Jailal. Without them, our unopposed meeting is conducted still now. As well as the guest of honor is our Dr. Suresh Balan sir, Dr. Trevi Mohan sir, Dr. Sunil Jagaran sir, Dr. Chitra, Dr. Mahilan. Welcome you all, sir. As well as all the IMA members and the viewers. Welcome you all for this nice evening with the meeting with the international faculties for the COVID update, international COVID update. I take this opportunity to invite the welcome both of the, introduce both the chief guests speakers also. First, Dr. Daniel Andane, who is the medical officer of International Infection Control Program, Office of the Director, Division Healthcare Quality Program, CDC. Dan is the medical officer of International Infection Control Program in the Division of Healthcare Quality Promotion, US Center for Disease Control and Prevention in Atlanta. And they received his Bachelor of Degree with the Wheaton College and his MD case of Wheaton Reserve University, and he completed his clinical residency in internal medicine and Vanderbilt University Yes, MPH from the Rollins School of Public Health, Atlanta. He also is completed his public policy fellowship at the Thatcher Health Leadership Institute in the Morrow School of Medicine. He participated in medicine and directed quality improvement initiative and domestic and international healthcare facilities prior to joining the CDC in 2015. He directed communicable disease program at the medical program administrator for the Flint Country Department of Health Wellness starting in 2015. He has served as a medical officer and international infection control program supporting the effort in Africa, Asia, as well as all over the world. And it's developed the policy and guidelines program to improve the surveillance system, infection prevention control, and antimicrobial stewardship and national, state, and facility level. Since 2018, he worked to support the effort to build the sustainable capacity to prevent, detect, and restore the healthcare associated infection in India. I welcome you, sir. Thank you very much. As well as Dr. A.S. Valan, MD, is son in soil. Dr. Daniel, I just talk in like our own language for 2 minutes. Like, your number Manin Mayandan, Nama Kanyakumari district is Sarndavar, Namal Indian Medical Association or Urupinarum Kuda, Namal Red Cross Society Urupinara Kranga. We are the public health specialist in infected disease for the Division of Global Health Protection, Center for Disease Control and Prevention, India Country Office and New Delhi. It supports infectious disease surveillance with the focus and activities improving the prevention, detection, and response to the antimicrobial resistance and surveillance of healthcare associated infection in India. Dr. Valan is a medical doctor with wide range of technical and public health program management experience in communicable and non-communicable disease. He has previously worked with the National AIDS Control Organization, International Training and Education Center of Health. He has worked as a trainee India Epidemic Intelligence Service Officer, National Center for Disease Control, India at the National Institute of Research in Tuberculosis, Indian Council of Medical Research and National Program for Cancer, Diabetes, Cardiovascular Disease and Stroke at MOHFW, New Delhi. He has also worked as a technical consultant for WHO India Country Office and WHO SEER Office in Bhutan and India. He has many national, international scientific publications to his credit and co-author chapter on healthcare associated infection in the National Guidelines for Infection Prevention and Control in Healthcare Facilities, Ministry of Health and Family Welfare, January 2020. Welcome you, sir, both of you. Like I called them like, I think so like 20 days back. I told them like the meeting will be conducted within 1 week. From that day, like I am not like behind them. Like Dr. Valan was behind me. Like the program is confirmed. Like when we are conducting and everything. Like there's so much support, and there was so much of discussion going on between us. Like what to talk with our people, what we needed, and everything. I thank you very much to join with us. Thank you, sir. Now I tell invite our Dr. Nagarajan, who is a senior member of our IMA NAGERCOIL, to inaugurate the program, sir. Dr. Nagarajan, sir, over to you, sir.
Hello. Hello. Am I audible to you?
Audible, sir. You're audible, sir.
Respected President of NAGERCOIL Branch IMA, Dr. KANYAKUMARI, Presidents, Secretaries, Treasurers of all IMA branches of our district, eminent IMA leaders, past President of India, Dr. K. Vijay Kumar, and present National Senior Vice President, Professor Dr. J. Jailal, guest of honors, Dr. Sunil Jayakaran, Dr. Preparedness Mohan, Dr. Chitra, Dr. Mahilan, and Dr. Suresh Balan, expert speakers on the topic hospital preparedness and infection prevention control COVID-19. Dr. A.S. Velan, epidemiologist, as he said, the son of our own soil, Dr. Daniel Bendant, Medical Officer, International Control for COVID-19, all members of IMA of our district, good evening to you all. It gives me immense pleasure to me to take part in this August occasion to inaugurate this second webinar. I offer my thanks to organizers, especially Dr. Shivakumar, for having honored me thus. It is really a great moment to continue our monthly IMA meetings every month through the webinars. And in fact, everyone used it. One thing that we cannot see, the lovely faces of our members every month. That's a pathetic part of it. And despite this lockdown, I am happy that our monthly meeting is being carried out regularly without any hindrance. The doctors have now, you see that our doctors have started to get their due importance of the government through the IMA. Thanks to Dr. C. N. Raja, the state president, who yesterday met the Honorable Minister, Health Minister and the Health Secretary and had a mutual talk and interaction with all the members of the IMA. And government has now come forward to realize the responsibilities, and they have recognized the members, the doctor members and their importance. And so far, it's so many times we were cheated, and now the government has come down and they have analyzed how the importance of doctors is. And it's a great movement. And yesterday we were given a lot of preferences just to save the public. We know our responsibility. The government need not say, and we do our duty to save the public, because it is them to make us to live. And on behalf of each and every one of you, I thank Dr. Shivakumar and all the members for having given me this great honor. And I am very much pleased to inaugurate this webinar of today. Thank you very much.
Thank you, sir. Thank you very much. I think so, like our guest of honor, like Dr. Professor Jailal sir is there. From not to tell from our mouth, like so many things happened, in like supporting the IMA for us. நேற்று கிடைத்த பரிசுகள் அப்படின்னு சொல்லணும் தமிழ் லைக் நம்ம ஐஎம்ஏ லைக் டாக்டர்ஸ் எல்லாத்துக்கும் கிடைச்ச ஒரு பரிசுகள் நேற்று நிறைய பரிசுகள் கிடைச்சிருக்கு ஃப்ரம் த சென்ட்ரல் ஐஎம்ஏ as well as the ஸ்டேட் ஐஎம்ஏ. அதை அவங்க சாரோட வாயலை கேட்ட சந்தோஷப்படலாம்னு நினைக்கிறேன். ப்ளீஸ் சார்.
Thank you, Siva. Thank you, dignitaries. I'm sure it is a great day for us. Though amidst the COVID pandemic, it is a time that it has been integrating both public and private sectors. The contribution of private sectors in the healthcare is immense, but the due recognition for the private sector contributions are not often given by the public health. The government always think that it is what is given by the government is much better than not the private sector. But now the time has come, the government is realizing the importance of the private sector and the contribution of the scores of doctors across the country. So based on that, Tamil Nadu is also having a very close relationship with the doctors, because we are fortunate, both the health secretary and the health minister belongs to our profession, our fraternity. So they have, at least finally, they have understood the nuances. If you see the 3 days back or 4 days back, the Hindu paper given a press note of a health secretary, which IMA has taken in a very seriously and taken the issue with her. So it has forced them to declare that government is in full support of the private practitioners, and the concerns of the private practitioners will be fully taken care. And the issues of the closure of the hospital, because previously it was a fear that when there is a corona positive patient come to our hospitals are being mudslid, and the media was projecting badly on that, and the government was also closing down the hospital for many days. But now the government has categorically decided and given an order that no government, hospitals, no private hospital will be closed just for the sake of there is a corona positive patient is there. It is only the disinfection will be given. So it gives a lot of confidence into the minds of the private practitioners to carry on their routine practice and open their clinic and make it available for their needy people. And also our very concern is getting the insurance sector covered for the private health sector. The government has provisionally decided and has assured that they will take care, and the insurance sector, the coverage will also cover to the all the private practitioners. not only on the state level, but we are taking it on the central level. And the central government has also, on the move of protecting the doctors. And we are also happy that the government has come forward to have the protect the doctors amidst this pandemic. The Hospital Protection Act, which we are asking for a long time, has been passed as an epidemic act. And probably, I'm sure in the coming parliament session, we will make it as an Hospital Protection Act. So all this, and as rightly said by Sivakumar, then another important aspect we got is the pollution control board. The hospitals are taken from the industry category to the non-industry category. Though it is a small step, but this is a good opportunity that we will be fighting for hospitals to be declared as the infrastructure, essential infrastructure. Once it comes as the essential infrastructure, we will get a lot of financial and lot of benefits. So once we are out of industrial sector, and it is very easy for us to try to get the infrastructure status, and I'm sure that IMA will work it on that. So I must also take this opportunity to congratulate Siva for excellent job. And the doctor's talent depends upon adapting to the situation. I'm sure in the adapting to this COVID situation, he has organized, this is the second conference, second webinar which he is organizing. And I'm so happy to have Dr. Valan with us. It's one of the privilege for Kanyakumari district. His contribution in the public health in the international and the national level is something phenomenal. Right from the days of the AIDS and till now, as an epidemiologist, he is contributing a lot. So it is a great honor for every Kanyakumari district people to have Dr. Valan with us at this great moment. So I welcome him. And I'm so happy that Dr. Daniel from UK is also interestingly participating with us. And that now today UK can to some extent say that they have won against the battle in the COVID. The cases are decreasing. The mortality has reduced. The taken care and the control over the COVID is excellent in UK. The phenomenal success amidst, in spite of the mounting cases, and they were able to overcome that problem. Daniel will be able to tell us the issues which we are going to face and how we will be able to fare them well. So thank you very much, Dr. Daniel, for being available with us. And I once again thank all our IMA leaders. And I'm sure in this COVID era, that let our unity, we get united furthermore, and let us, with altruism, we will serve for the community so that we will be able to get rid of this COVID pandemic in a very positive way in the days to come. Thank you all.
Thank you, sir. Thank you. I think so. Last time the meeting was in a different way. Like the question was put forward to us, like all the panelists who are sitting here. But today, what we are going to do is like all of us is going to throw the question to Dr. Daniel as well as Valan. Right, Valan? It's accepted. Thank you. So we'll start the first small talk on hospital preparedness and infection prevention and control for the COVID-19 by Dr. Daniel.
Dan, you are on mute. You can unmute and share your screen.
There we go. Thanks. So it's a real privilege to be here. I've heard a lot about your organization. Thank you, Dr. Sivakumar, for the invitation, the IMA leadership, for all of the participants that are out there. We are here to serve you and really want to provide you the information that you want. So as we've discussed, a lot of this will be around your questions, and we'll get to them, and as many as we can. And if we don't know, because this is a broad topic, we will endeavor to find answers for you. So I'm going to begin by just sharing some information as a starting point. So as you've in the introduction really said well, is that our goal here is to provide appropriate care to all of the COVID patients as well as those that don't have coronavirus. And we hope that there's not an overwhelming number of patients that present so that the best care can be provided. As in Italy, as in New York, even I think in Mumbai, there's a time where there's so many patients, it becomes difficult and appropriate care changes. But we hope that with social distancing and the public health measures that this doesn't happen in Tamil Nadu. as you've discussed, a primary concern is to protect your healthcare workers. We are really focused on making sure that you as healthcare workers do not get infected. We also want to make sure that the hospital is not a disease amplifier. That means that as physicians, as nurses, as healthcare workers go into the hospital, they're not the cause of spread. And this is a very real concern, cases in Korea, Japan, and many parts of the world where healthcare providers are going in and actually being a cause of the spread. And of course, we want to protect our patients who do not have coronavirus, those that have HIV, those that have cancer, that need chemotherapy, those that need surgery as an emergency, or increasingly where surgeries that have been postponed that are really needed. How do we protect them to maintain these essential services? So I want to go into some of the more recent evidence, which I think will inform you on the risks that you take and the patients that come to you. So this was a study that was done published about 3 days ago, where in a loud voice, when people said, stay healthy, there was droplets that were transmitted into the air, and in a closed, stagnated space, they remained. This is a light scattering diagram which shows over time. Again, this speaks to this virus can be transmitted by just talking in a closed space, something to consider when you're taking care of patients and you're close with them. Another example of this is that one individual went to a choir practice. That particular individual infected the majority of the choir members just by singing, just by being close. 3 of those patients were hospitalized and 2 ended up dying. Again, this speaks to when patients are coming into the clinic and they're relatively asymptomatic, or providers are in the clinic and they're relatively asymptomatic, it can be spread. You can see from this is the same study that the index patient had symptoms, went to the choir practice and resulted in an outbreak, if you will. This is not unlike what we would see in a hospital with an index patient who has coronavirus and is seen by many, many hospital providers, cleaners, nurses, respiratory therapists, and then you end up with a cluster of cases. We know that households are very much a part of the spread. This is a study from Wuhan which showing that it's mainly household contacts that were responsible for the spread of coronavirus. And as a corollary to that study, when there was separation of an infected individual from their house, transmission was decreased. This is a study that was done, a small study to demonstrate that in the intubation, the active intubation, there's a lot of droplets that were generated. And in the use of PPE, they had these fluorescent markers that showed there was exposure to the skin. And so this is, of course, a risk for anyone that's doing intubation or dealing with aerosolized generating procedures, that you can get contaminated and you should be concerned. This is a study of an individual who presented to the hospital, ended up in the intensive care unit, and this particular individual was not recognized as having COVID. 121 providers then were exposed. Some were not high risk, some were moderate risk, and some were low risk. If we look at the data for this study, one of the key elements is the lack of personal protective equipment. Those that were wearing personal protective equipment, it was protective. Again, this is a message that we don't know in a situation where there's widespread community transmission who has the virus, or even providers if they're bringing the virus to the hospital. So wearing PPE is important. In this study, so the question here is, what's the risk for healthcare workers? So in the US, they took all healthcare workers, that reported as healthcare workers, and they said, how many of them are there? So overall, 3% to 11%. In states that really had higher reporting of healthcare worker status, it was up to 11%. So if we use this as a corollary, at least 3 to 11% of the healthcare workforce is going to be exposed and are going to present as cases, but likely this is an underestimate. It's important to note that only about half of those were exposed, they feel, in the healthcare setting. So community transmission for your healthcare workers is a big concern. So just because they test positive doesn't mean they got it in the hospital. They could very well have gotten it in the community. You cannot 100% say one or the other. You have to consider both. The good news is that most of the patients recovered, but those that died were in the higher age group with comorbidities. So it's no different than the patients who are presenting to the hospital. Those providers that are at risk because of their age or because of comorbidities are still the ones that are going to be having symptoms. And the other thing that I think is really important is 8% of the healthcare providers did not report any symptoms, meaning that you can have asymptomatic healthcare providers who feel fine, but actually are testing positive. This is why it's very important for all healthcare providers to recognize that they could transmit as well. Where you have, so the question in this particular slide that I want to emphasize is, where are you at risk? So they took air samples from public areas and hospitals. And I think the key message on this slide is that if it's well ventilated, it's better. If it's a closed space and it does no air exchange, such as a small unventilated bathroom, that's higher risk. If there's decontamination of the environment on a regular basis, it's protective. And specifically in areas where providers were removing their PPE, once those areas were well cleaned, you had less viral load. So protect yourself by doing environmental cleaning. This is another study that shows that asymptomatic carriers, so 215 women in New York City coming for healthy delivery, they all come, they're all tested. Of the 215, 33 are positive, but only a fraction, around 2% were symptomatic, meaning that you had a little over 1 out of 10 women presenting for a delivery screening positive. Again, this is an impact on when you're considering how do you reopen your clinics, how do you reopen for surgery. If you're going to do this, you have in a setting where there's community transmission, you have to expect to see people that are asymptomatic that have coronavirus. A nursing home study, again, this is the same message. They had an outbreak case that was identified early. They put in appropriate IPC, infection prevention control measures. They tested the staff, they tested the patients. It still spread because it's highly transmissible. Many people were testing positive in having no symptoms. This is a nice graph from the New England Journal of Medicine showing that in the pre-symptomatic phase, you can transmit it. In the symptomatic phase, you can transmit it. And after symptoms, it's unknown. And we'll kind of touch on that in the following slides. So bottom line for CDC, continue to recommend N95s when you're close to the patient because of this transmissibility at close range. How long do you remain infectious? So it's a couple nice studies, and this is all summarized at the website here at the bottom very nicely, and I recommend that you look at this site. So over time, you can see that the log count for the RNA goes down. And if you look at the second graph, a key thing to look at is the positive culture. So there's a difference in RT-PCR, which just detects is the virus, some part of the virus there, versus a viral culture, which says you can actually culture a live virus. So after around 10 days, that virus can't be, there's no positive culture. And if we look at this unpublished data, which is on the website, this also kind of correlates and says that the ability to culture this virus drops off 9 days and then approaches 0 at 10 days. So we can postulate here that once you have symptoms and you count 10 days from when you have symptoms, the likelihood of culturing a live virus is not going to be very high. It approaches 0. So this kind of sets us up for how long do we allow healthcare workers to remain off of work before we allow them to come back. You can see from this study that the actual detection of SARS in patients can persist for up to 6 weeks. So you're gonna, if all you're doing is RT-PCR and people are consistently positive, it doesn't mean that they're infectious to others. It just means that the SARS-CoV is there too. But because we're still learning about this virus, we have to be careful to say that this is an absolute. So evidence suggests that once somebody has symptoms, 10 days out, they're not going to be able to transmit, but that still is a work in progress. And this is a nice graph where you can see that it is kind of laid out what we just talked about. So in week 1, you have a rise of the virus, a lot of early transmissibility, PCR becomes positive, and antibodies then become detected. And the whole, we won't really get into the whole antibody because that's, well, I guess we will get into that. So another thing to consider, now this is also something that a lot of evidence is needed, but it really is going to impact you, is what happens when somebody is completed their coronavirus and they go out. We know that some viruses in the coronavirus family have a very short immunity. So 3 months and they can get reinfected. There is some evidence that there is immunity, some study on macaques. If we look at some other studies out of Shanghai, not everybody develops antibodies. If you have a more severe infection, if you're older, you might have a higher ability to generate antibodies, but we don't know if those antibodies are actually protective. Studies of human volunteers with the seasonal coronavirus had antibodies and they still got reinfected with symptoms. If we look at SARS and MERS, the protection for coronavirus is not forever. SARS maybe 3 years, MERS around a year. So, you know, in the US, there's hospitals that are flagging patients that had coronavirus. And so when they come back to the emergency room and they say, well, we've already had coronavirus, what do you do with those patients if they have similar symptoms of coronavirus? I think that's a really unanswered question that can impact a lot of your patient care. We also know that other viruses can be co-infected. So many examples of patients that have had influenza or RSV and also had SARS. So just because you have one virus doesn't mean that you don't have 2, although the numbers are small. So all that to say, the CDC now has recommendations on a test-based strategy for healthcare workers and a non-test-based strategy. So if you use a test-based strategy, you exclude from the work, they have no fever, they're not using any fever-reducing medications, they've improved symptoms, and they have a negative test. Now, this is going to be different from India because the guidance just came out, and I'm going to ask Valin to speak on that right after this. And also non-testing strategies. So I'm just going to exclude you from work until you have no symptoms or 14 days have passed. And then I'm allowing you to go back. But you still have to do hand hygiene. You still have to do respiratory hygiene. You still have to make sure that you are self-monitoring for symptoms. And the caveat with this is that if you're going back to an area that has a high-risk population, you go back and you work in a cancer ward or an HIV ward, or you go back to work in a nursing home facility, I think you still have to be very careful because the evidence is not definitive that you can't transmit. Valin, do you want to say anything about the India recommendations?
Yes. So what India recommends is for, sorry, okay. Yeah, for what Ministry of Health and Family Welfare in the recent guidelines, they recommend is for severe and moderately severe cases, like for only for severe cases, they recommend testing at the end of 14
We'll
days.
just keep moving.
Hello?
Yes, I can hear you.
Okay. So for mild and moderate cases, India doesn't recommend any testing. For mild cases, like mildly symptomatic cases, just fever shouldn't be there. And after 10 days, like what they do is they monitor, and after 10 days, they will be discharged if there is no symptom. Moderate cases, there are two categories. Like first category is the fever should resolve within 3 days, and to saturation should be maintained without support after that. So after 10 days, those patients will be discharged, and there is no need for RT-PCR test before discharge. So another case of moderate cases who require oxygen therapy, like symptoms not resolved within 3 days and they continue to have oxygen therapy for more times. In these patients, they will be discharged only after their symptoms resolve completely, no fever, and at least 3 days they should be off from the O2, and they should be taking a normal breathing. So then be discharged. Again, here there won't be any testing using RT-PCR. In this cases, you will be discharging after clinical recovery. You will be again testing. Like if it was a severe case on ventilator, so then in these type of cases, you will be testing after 14 days. And after the test comes negative, then only they will be discharged. So here comes another question from the field. So some patients, even like they keep on getting tested positive. Test was done on 14th day, they tested positive. Again, the test was repeated on next day. Again, the test is positive. So what is the guideline for this? So some of the hospitals like AIMS, what they follow is they test at 14 days. If it is still positive, they wait for another 5 days. And after 5 days, they test again. And if they test positive, they wait for another 5 days and test again. So this is the strategy followed at All India Institute of Medical Sciences, New Delhi. But government guidelines doesn't any distinguish like what to do if a test repeatedly comes positive. So we like us AIMS is doing this. Like this is one of the guidance we get, but there are no clear guidelines. If somebody gets tested positive multiple times after the 14th day of discharge, like mainly for the severe cases. As you rightly said, the viral shedding still be there. It can go beyond like some 3 to 4 weeks also. But the viability of virus is a question mark. Whether he will be infective or not, that will be a big question mark. Yeah.
So this slide, we kind of talked through about some persons needing additional testing. So I'm gonna shift a little bit, and we're not going to go through all of this, but I want to hit some key things, especially triage, because triage is something that you have to consider so that you protect yourself and vulnerable populations that you work with. So in triage, you want to make sure that you're triaging patients almost before they come to the hospital. And this is to make sure that all patients who have potentially coronavirus are not entering the healthcare system where healthcare staff is not aware, or they could expose other patients. So what patients can do is that be aware of the symptoms. Now, we used to say that it was just cough, fever, and shortness of breath as screening. The CDC has updated the revised symptoms based on evidence and also included repeated shaking with chills, muscle pain, headache, sore throat, and new loss of taste or smell as screening criteria. So this is something for you to consider is, what are your screening criteria that you're using for patients who are presenting? Because not everybody is presenting with just fever, cough, and shortness of breath. What patients also can do is, if you have telemedicine, to use telemedicine, always ask them to wear a face cover, making sure that if they do have symptoms, they're notifying staff immediately. And often you can have signage that they can do that. Wash their hands. And if they're touching a lot of surfaces, making sure they have tissue or something that they can cover their mouth, and then maintaining distance. What facilities can do is communicate, set up your triage, making sure that your respiratory waiting area is adequate. So hotlines, mass media, telemedicine are all things that you can do, and many facilities are doing that, making sure there's clear signs saying that they should stop, and have registration desks with a barrier protection, having some plastic or glass between the patients and the healthcare workers in order to protect them. This also may reduce the amount of PPE that you have to give your frontline staff that are registering patients. So here you have an example where you have a triage center with plenty of face masks and paper tissue, a place for discarding that, hand washing stations, and this glass barrier that's between the patient and the provider. This is just a visual example of how you can set up your waiting room to make sure that there's space. I think many of you have done this, but if you haven't, consider how can you social distance in your waiting areas. Visual alerts, this is a respiratory waiting area, and even in places where you have regular patients, you still need to have social distancing because of the risk of asymptomatic carriers. Having a standardized algorithm, again, some of these slides are on CDC, so I'm going through them. So in the setting of a widespread community transmission, making sure that you're screening for symptoms. If they have any kind of these symptoms, you're immediately giving them a mask or asking them to cover their face with some kind of cloth, and then separating them in isolation rooms. And this is just a different way of looking at it. Having signage, separation of them into two cadres, one that with symptoms, one without symptoms, but always keeping that meter regardless. And it's very, very important to have disinfection. So you must be disinfecting your environment. We know that this environment from studies that were in Nebraska and Singapore, where they had coronavirus patients and they sampled the environment, that it does contaminate the environment. The good thing is that it kills the virus. Now, this is a slide that CDC had as 0.5. I believe that WHO in the near future is going to come out and say disinfect with 1% chlorine. I think that's just out of an abundance of caution. And then 70% alcohol. Healthcare workers always adhere to standard precautions. This is not something that should be done only with coronavirus. Wear your PPE. The number, very, very important that you take off your PPE appropriately. One of the highest points for healthcare workers to get coronavirus is when you take off the gown, take off the gloves. You have to do it in series. Many hospitals are stationed staff to help healthcare workers remove their PPE safely so that they don't self-contaminate. You don't want to be touching your face or eyes or your mask or your face shield without doing hand hygiene. Please make sure that you take time to take off your PPE appropriately. I think that, you know, these are just some examples of setting up a PPE outside centers. And I think I'm going to stop there because to give time, we'll have time for questions and we can go to some of the material later.
So Dr. Shivakumar, like you had a lot of questions regarding what PPE is to be used, regarding the aerosol generating procedure PPEs, and like what shall I project those slides? So like optimal use of personal protective equipments in healthcare is, because there were a lot of questions which you highlighted, mentioned about this. Shivakumar sir?
Yeah, please. I'm just
see my slides.
Yes, yeah.
So இதுல இருந்து ஸ்டார்ட் பண்ணுவோமா சார்?
கண்டிப்பா அங்கே இருந்து ஸ்டார்ட் பண்ணலாம். And like everybody can join with us, like அவங்களோட கருத்துக்களையும் அவங்க பதிவு செய்துக்கலாம், and they can
கண்டிப்பா வந்து they can, கண்டிப்பா உங்களோட கருத்துக்களை நீங்க சொல்லுங்க. சோ நமக்கு வந்து இப்போ பிபிஇ வந்து எங்க தேவைன்னு பாத்தீங்கன்னா, நமக்கு வந்து முக்கியமா வந்து பேஷண்ட் கேர், கோவிட் பேஷண்ட் கேர்லயோ இல்லது ட்ரையாஜ்லயோ யாராவது இருக்காங்கன்னா அவங்களுக்கு தான் முக்கியமா வந்து பிபிஇ தேவை. சோ அதுலயும் வந்து முக்கியமா வந்து நம்ம வந்து டிஸ்டன்சிங், பிசிக்கல் டிஸ்டன்சிங் அட்லீஸ்ட் 1 மீட்டர் நம்ம மெயின்டைன் பண்றோம். கிளினிக்கலி எக்ஸாமின் பண்ணல அப்படின்னா வந்து சாதாரண மாஸ்க், ஒரு ஃபேஸ் ஷீல்டே போதும். சோ இன் கேஸ் வந்து நம்ம வந்து பேஷண்ட் கேர் கொடுக்குறோம், அது அந்த கேர் கொடுக்குறோம். பட் ஏரோசால் ஜெனரேட்டிங் ப்ரொசீஜர் எதுலையுமே நம்ம இன்வால்வ் ஆகல. இன்கேஸ் லைக் அந்த மாதிரிப்பட்ட சிச்சுவேஷன்ல வந்து நமக்கு வந்து சாதாரண மாஸ்க் போதும். பட் டாக்டர் டான் வாஸ் மென்ஷனிங் என்னன்னா வந்து த்ரூ டிராப்லெட்ஸ் வந்து இட் கேன் ஸ்ப்ரெட். ஸோ சர்ஜிக்கல் மாஸ்க் வந்து ஒரு சர்டன் அமௌண்ட் தான் நமக்கு வந்து ப்ரிவென்ட் பண்ணும். ஸோ அதனால வந்து ஒரு ஃபேஸ் ஷீல்டோ இல்லது ஒரு கோகுல்ஸோ அலாங் வித் ஃபேஸ் மாஸ்க் நீங்க யூஸ் பண்ணீங்கன்னா the chances of getting the infection when you are working in a OPD like situationல வந்து ரொம்ப ரொம்ப கம்மியாகும். மெயினா ஃபேஸ் ஷீல்ட் யூஸ் பண்ணா, ஏன்னா வந்து ஸ்பிளாஷ் ஆனா கூட நமக்கு வந்து வராது. ஸோ அதுக்கு முன்னாடியே வந்து பேஷண்ட் என்ன சொல்லணும்னா கண்டிப்பா எனிபடி who comes into a health facility அவங்க வந்து கண்டிப்பா மாஸ்க் போட்டிருக்கணும். ஸோ அவங்க மாஸ்க் போட்டிருக்கும் போது அவங்க வந்து எக்ஸேல் பண்றதோ இல்லது வந்து அவங்க தும்மும் போது வர்றதோ உள்ள அந்த நம்பர் ஆஃப் வைரஸஸ் டிராப்லெட்ஸ் வந்து நமக்கு வந்து இட் வில் பி சிக்னிஃபிகன்ட்லி டவுன். ஸோ அதனால எல்லாருக்கும் நமக்கு N95 மாஸ்க் தேவை, ரெஸ்பிரேட்டர் தேவையா ஓபிடில எல்லா இடத்துலயும்னா, ஸோ இஃப் யூ ஆர் ஹேவிங் எனஃப் குவான்டிட்டி, பிகாஸ் உங்களுக்கே தெரியும் N95 எல்லா இடத்துலயும் அவைலபிள் கிடையாது. குவான்டிட்டி இருந்ததுன்னா நீங்க யூஸ் பண்ணலாம். மற்றபடி வந்து சாதாரண சர்ஜிக்கல் மாஸ்க் அலாங் வித் அடிஷனல் ஃபேஸ் ஷீல்ட் இஸ் மோர் தென் எனஃப். உங்களுக்கு வந்து லாட் ஆஃப் பார்ட்டிகல்ஸ் அதுவே ப்ரிவென்ட் பண்ணும். ஆல்சோ யூ ஷுட் கிவ் மாஸ்க் டு பேஷண்ட்ஸ். ஸோ மாஸ்கோ இல்லது ஃபேஸ் கவரோ கண்டிப்பா வந்து பேஷண்ட் யூஸ் பண்ணதுக்கு சொல்லணும், எல்லா பேஷண்ட்டுமே, those who are coming to your hospital. இது வந்து ரொம்ப ரொம்ப முக்கியமானது. ஸோ அதே மாதிரி பாத்தீங்கன்னா வந்து கிளீன் கவுன் வந்து நீங்க போட்டுக்கலாம். அதே மாதிரி கிளவுஸ் யூஸ் பண்றது வந்து நான் ஸ்டெரைல் கிளவுஸ் யூஸ் பண்ணா போதும். ஸோ யூஸ்வலி வந்து நீங்க கிளவுஸ் யூஸ் பண்றதா இருந்தா ஈச் அண்ட் எவ்ரி பேஷண்ட்டுக்கு வந்து யூ ஹேவ் டு சேஞ்ச் த கிளவுஸ். யூ ஷுட் நாட் பி யூசிங் த சேம் கிளவுஸ் ஃபார் ரிப்பீட்டட்லி சீயிங் மல்டிபிள் பேஷண்ட்ஸ். என்னன்னா வந்து ஒரு பேஷண்ட்டுக்கு இருக்கும் ஏதாவது டிராப்லெட், இது வந்து ஃபோமேட் டிரான்ஸ்மிஷன் உங்களுக்கு நல்லாவே தெரியும். ஸோ இட் கேன் டிரான்ஸ்மிட் ஃப்ரம் ஒரு பேஷண்ட்டை பார்த்துட்டு அடுத்த பேஷண்ட் தொடும்போது இவருக்கு இருந்திருக்கும் அவருக்கு இருந்திருக்காது. யூ வில் பி ஆம்பிளிஃபைங் the spread of the virus. So அதனால வந்து ரொம்ப கேர்ஃபுல்லா வந்து நீங்க இருக்கிற கிளவுஸ் போடுறதா இருந்தா சேஞ்ச் பண்ணுங்க. இல்லைன்னா எவ்ரி பேஷண்ட் யூ ஷுட் வாஷ் யுவர் ஹேண்ட்ஸ் ஆர் லைக் யூ ஆல்கஹால் பேஸ்ட் ஹேண்ட் ரப் இருந்ததுன்னா யூ ஹேவ் டு கிளீன் யுவர் ஹேண்ட்ஸ் ஆஃப்டர் சீயிங் ஈச் அண்ட் எவ்ரி பேஷண்ட். ஸோ எப்பவுமே வந்து டிஸ்டன்ஸ் மெயின்டைன் பண்ணுங்க, ஃபேஷியல் யூஸ் பண்ணுங்க அண்ட் மாஸ்க் யூஸ் பண்ணுங்க. இஃப் யூ ஆர் இன்வால்வ் இன் ஏரோசால் ஜெனரேட்டிங் ப்ரொசீஜர் எதுலையாவது நீங்க இது இன்வால்வ் ஆயிருந்தீங்கன்னா, ஸோ முக்கியமா வந்து ஏரோசால் பண்ற ப்ரொசீஜர் இருக்கிற இடம் வந்து வெல் வென்டிலேட்டடா இருக்கணும். ஸோ எய்தர் இட்ஸ் அன் ஐசோலேஷன் வார்டா இருக்கலாம் இல்லது ஐசியூவா இருக்கலாம். அந்த ப்ராப்பர் வென்டிலேஷன் சிஸ்டம்ஸ் வந்து நீங்க பண்ணிருக்கணும். அந்த டக்ட் எல்லாம் கரெக்டா வந்து பியூரிஃபை ஆகி வெளியே போற மாதிரி பண்ணிருக்கணும். ஆல்ரெடி வந்து கவர்மெண்ட் ஆஃப் இந்தியால இருந்து தேர் ஆர் கைட்லைன்ஸ் ஹவு த ஏர் ஷுட் பி சென்ட் அவுட் அண்ட் ஆல். ஸோ அதை வந்து நீங்க ப்ராப்பரா ஃபாலோ பண்ணுங்க. அதே மாதிரி எனி ஏரோசால் ஜெனரேட்டிங் ப்ரொசீஜர், அது இன்டுபேஷனா இருக்கலாம், எக்ஸ்டுபேஷனா இருக்கலாம், நெபுலைசேஷன் கொடுக்குற இடமா இருக்கலாம், இல்லது வந்து சர்ஜரி ஓடிஸ். ஏன்னா வந்து ஈவன் when you are cauterizing like that generates aerosol. அல்லது லேபா இருக்கலாம். all these places where there is a possibility of aerosol generation or like anesthesia கொடுக்கிற இடம் எல்லா இடத்துலயுமே வந்து definitely all the healthcare providers should be wearing a particulate respirator. N95 யூஸ் பண்ணலாம். N95 is the American standard, NIOSH standard படி, இல்லது FFP3 which is a UK standard. So these இது வந்து இந்த ரெண்டு கண்ட்ரி ஸ்டாண்டர்டும் நம்ம யூஸ் பண்ணலாம். So இந்தியால பாத்தீங்கன்னா DRDO has their own standards. So you can refer to HLL Life Care Limited like government ஓட இது. So அதுல போனீங்கன்னா உங்களுக்கு guidelines வந்து தெரியும். So I'll stop here and இன்னொரு முக்கியமான விஷயம் then I'll stop. So என்னன்னா கவர்ஆல்ஸ் இது வந்து நிறைய பேர் கேக்குறாங்க. அந்த ஹாஸ்மெட் ஷூட்ஸ் எல்லாரும் வந்து இந்த படம் எல்லாம் பார்த்து they are so fancied about using a hazmat suit and all. So is it needed for COVID-19? No, it is not a standard recommendation. Hazmat suit ஓ கவராலோ வந்து இதுக்கு தேவையில்லை. இதுல முக்கியமா பார்க்க வேண்டியது coverall and hazmat suits when you are using the donning and doffing procedures are completely different than the recommended usual procedures. So அதனால வந்துட்டு you have to be really careful while donning and doffing this. And as for COVID, nobody recommends this unless there are no PPEs, regular PPEs available, usual gowns illa அப்படின்னா நீங்க hazmat suits coverall யூஸ் பண்ணலாம். மற்றபடி இந்த level of protection is needed for hemorrhagic fevers like Ebola, Nipah இந்த மாதிரிப்பட்ட கண்டிஷன்ஸ் எல்லாம் தேவையே தவிர கோவிட்க்கு வந்து இட்ஸ் a droplet based infection. It is not recommended neither by WHO or CDC unless there is a shortage of other PPE kits. So I'll stop here. Dan already mentioned about donning and doffing importance. So Matha panelists on the you can give your comments about using PPE in the OPD, adhe madri ICUs and isolation wards matha edathila. So any other comment?
Okay, well, like I think so now konjam questions prepare pannirkom. Adha will put forward the same time like the
okay,
there in the panelists they can ask the questions also.
Okay, sure. So நீங்க ப்ரொஜெக்ட் பண்றீங்களா சார் இல்லது shall I move regarding PPEs?
I'll just project some questions.
Okay, for sure, sir.
Then again நீங்க திரும்ப வந்துடலாம். We can come back.
Okay, thank you, sir.
நீங்க எக்ஸிட் ஆகணும். நீங்க ஷேரிங் எக்ஸிட் பண்ணுங்க.
Oh, sorry. நான் ஷேர் ஸ்கிரீன் பண்ணலையே சார்.
Okay, no problem. Right.
Okay.
See, like nowadays, like what happened is like we are even the private hospital started COVID-19 collecting the samples like to send to the government hospital or the private labs. What is the guidelines for collecting and handling and testing the clinical specimen from the COVID-19 patient?
Sir, I'll share some slides.
Please.
Okay. Just நீங்க unshare பண்ணனும் sir.
கண்டிப்பா பண்ணிடுவேன். Done, ma.
Thank you, sir. Okay. So, if a ministry guidelines என்ன சொல்லுதுன்னா, you have to collect nasopharyngeal or oropharyngeal swabs வந்து இந்த routine testing வந்து நீங்க வந்து collect பண்ணணும். So அதை வந்து collect பண்றதுக்கு முன்னாடி it has to be prescribed by a qualified physician. So இவங்க prescribe அந்த ஃபார்ம் இருக்குது, ஃபார்ம் fill up பண்ணி கொடுத்தாதான் வந்து நம்ம வந்து அந்த சாம்பிள் வந்து அக்செப்ட் பண்ணுவாங்க கவர்மெண்ட் ஃபெசிலிட்டில. ஸோ உங்க ஃபெசிலிட்டியில வந்து PCR ஆல்ரெடி வந்து if it is available na, you can write to your regional laboratory which is coordinating with NIV Pune ICMR. So அவங்கள்ட்ட இருந்து பெர்மிஷன் கொடுத்தாங்கன்னா you can test in your laboratory also after getting permission from Pune. So இதுல வந்து if you are referring, so you have to take the sample either from nasopharyngeal plus both nasopharyngeal and oropharyngeal இருந்து ரெண்டு சாம்பிளும் எடுக்கணும். ரெண்டையும் ஒரே இதுல போட்டு அனுப்புனா வந்து the sensitivity increases, you know, like if you are putting the same vial in the viral transport medium, உங்களுக்கு வந்து sensitivity increase ஆகும். ஸோ இதுல வந்து ஆல்ரெடி வைரல் டிரான்ஸ்போர்ட் மீடியம் வந்து உங்களுக்கு கொடுத்துருப்பாங்க உங்க ரெஃபரல் பண்றதுக்கு. ஸோ அந்த பிடிஎம்ல போட்டு தான் வந்து சாம்பிள் அனுப்பணும். சாம்பிள் எடுக்கும் போது வந்து யூ ஹாவ் டு பி வெரி வெரி கேர்ஃபுல் பிகாஸ் த பர்சன் ஹூ இஸ் டேக்கிங் சாம்பிள் is at high risk of exposure. So he should be wearing the PPE, first important. So main வந்து face shield is a must. இன்னொன்னு வந்து பேஷண்ட்டுக்கு சாம்பிள் எடுக்கிறதுக்கு முன்னாடி வரைக்கும் let him wear a mask. So while taking the sample, then you can tell him to remove the mask and take the sample immediately. So சாம்பிள் எடுத்த உடனே வைரல் டிரான்ஸ்போர்ட் மீடியத்துல போட்டுட்டு அதை வந்து ப்ராப்பரா வந்து ட்ரிபிள் பேக்கேஜிங், அந்த ஜிப்லாக் பேக் போட்டு ட்ரிபிள் பேக்கேஜிங் பண்ணி ஸோ ஷாக் எதுவுமே அஃபெக்ட் பண்ணாம அதுல வெளியே வந்துட்டு அந்த ஐயாட்டா கைட்லைன்ஸ் படி இந்த கேட்டகரி பி பயோசேஃப்டி இது வந்து நம்ம வந்து இம்ப்ளிமெண்ட் பண்றோம் இதுல. ஸோ அந்த ஸ்டிக்கரை ஒட்டி யூ ஹாவ் டு டிரான்ஸ்ஃபர் தட் சாம்பிள் டு தி நியரஸ்ட் ஃபெசிலிட்டி. உங்க ஃபெசிலிட்டியில நீங்க பண்றதா இருந்தா நீங்க வந்து அங்க வந்து நீங்க டிரான்ஸ்ஃபர் பண்ணிக்கலாம். ஸோ நீங்க வந்து இன் கேஸ் வந்து ரிசீவ் பண்ற இடத்துலயும் வந்து யூ ஹாவ் டு பி வெரி கேர்ஃபுல். அது உடையாம வந்து நம்ம வந்து பாத்துக்கணும். ஸோ இமீடியட்லி இட் ஹாஸ் டு பி டேக்கன் டு அ PCR lab. It has to be opened under the biosafety hood ல வச்சு தான் ஓபன் பண்ணணும். BSL2 இருக்கிற biosafety hood வந்து அதுல biosafety cabinet உள்ளாடி வச்சு தான் ஓபன் பண்ணணும். So then you can process further for PCR like taking adequate standard precautions. This is very very important. So இன்னொரு question வரலாம், other than nasopharyngeal and oropharyngeal வேற என்ன எடுக்கலாம்? For example, I have a patient in ICU who is having acute respiratory syndrome. ARDS இருக்குது இந்த பேஷண்ட்டுக்கு. ஸோ இவங்களுக்கு வந்து என்ன சாம்பிள் எடுக்கலாம்னு பாத்தீங்கன்னா, யூ கேன் டேக், அதாவது இன்டுபேஷன் சமயம் வந்து நீங்க அந்த ஃப்ளூயிட் எடுத்து அனுப்பலாம். ஸோ ஆல்சோ யூ கேன் டேக் ஸ்பூட்டம், தட் இஸ் ரெக்கமெண்டட் இன் த கரண்ட் கைட்லைன்ஸ் ஆஃப் ICMR. ஸ்பூட்டம் எடுத்து அனுப்பலாம்னு சொல்லி கொடுத்துருக்காங்க. அண்ட் ஆல்சோ யூ கேன் டேக் ட்ராக்கியல் ஆஸ்பிரேட் ஆர் பேல். ஸோ பேல் எல்லாம் பாத்தீங்கன்னா ஒரு சிவியர்லி சிம்டமேட்டிக் பேஷண்ட்ல வந்து the yield will be more. ஏன்னா ஆல்ரெடி லோவர் ரெஸ்பிரேட்டரி ட்ராக்டுக்கு போயிட்டுதுன்னா the viral load will be more and the chances of getting positive like the கோவிட் இருந்ததுன்னா வரக்கூடிய பாசிட்டிவா வரக்கூடிய சான்சஸ் வந்து அதிகம் லைக் இன் PCR. ஸோ அதர் தேன் நேசோஃபேரஞ்சியல் ஓரோஃபேரஞ்சியல் ஸ்வாப் நீங்க என்ன எடுக்கலாம்னா ET ஆஸ்பிரேட் எடுக்கலாம், ஆர் யூ கேன் டேக் ஸ்பூட்டம் ஆர் யூ கேன் டேக் ட்ராக்கியல் ஆஸ்பிரேட். ஸோ இதெல்லாம் வந்து அதர் ஆப்ஷன்ஸ் which is again recommended by ICMR and also recommended by CDC and WHO the guidelines. ஸோ இதுல வந்து லைக் இண்டக்ஷன் இதுல முக்கியமா வந்து நீங்க பார்க்க வேண்டிய ஸ்பூட்டம் எடுக்கலாம், பட் ஸ்பூட்டம் வந்து எந்த காரணத்தை கொண்டு இன்டியூஸ் பண்ணக்கூடாது. ஸோ இன்டியூஸ் ஸ்பூட்டம் இஸ் நாட் ரெக்கமெண்டட் நெய்தர் பை கவர்மெண்ட் ஆஃப் இந்தியா கைட்லைன்ஸ் நார் பை CDC or WHO கைட்லைன்ஸ். ஸோ நேசோஃபேரஞ்சியல் ஸ்வாப் வந்து அகைன் வெரி வெரி இம்பார்ட்டன்ட். ட்ரெயின்ட் கிளினிஷியனோ இல்லது ட்ரெயின்ட் லேப் ஸ்டாஃபோ மட்டும்தான் எடுக்கணும். நாட் எவ்ரிபடி can take nasopharyngeal swab. So you have to be really provide adequate training for people. So you might be aware of Kerala and Tamil Nadu kuda some sites and also in other states they are using this in the walk-in kiosk mari use pannanga. So this is another thing which will reduce the number of PPEs you are using, and also like it gives very good protection for the people those who are testing. You know, the lab technician pathina ulla irukkaru, sorry in the slides expand பண்ணிருக்கேன். லேப் டெக்னீஷியன் உள்ள இருக்கிறாரு, ஒவ்வொரு பேஷண்ட் வந்து அவர் பிபிஇ கன்சம்ஷனை வந்து சிவியர்லி மினிமைஸ். பட் ஒரு இம்பார்ட்டன்ட் இது என்னன்னா, கேரளால என்ன பண்ண, ஜஸ்ட் ஆஸ்க் டு ஒன் ஆஃப் த கிளினிஷியன் ஹவு தே ஆர் டிஸ்இன்ஃபெக்டிங்னு கேட்டேன். ஸோ தே ஆர் ஸ்ப்ரேயிங் அண்ட் ஹைப்போக்ளோரைட் வச்சு ஸ்ப்ரே பண்ணிட்டு அதுக்கு பிறகு ஒரு 1 minute கான்டாக்ட் டைம் கொடுத்துட்டு அதுக்கு பிறகு தான் அடுத்த பேஷண்ட் எடுக்கிறாங்களா. ஸோ தட்ஸ் ஹவு தே, பிகாஸ் வெளியே இருக்கிற கிளவுஸ் அப்படிதான் இருக்கு. அதனால வந்து எப்படி டிஸ்இன்ஃபெக்ட் பண்றாங்கன்னா this is how they disinfect. So இன்னொரு இது வந்து ICMR has now given provision for private labs to go and take samples from homes also. So some private labs mobile vans மாதிரி வச்சு பண்றாங்க some placesல. So again when they are doing, they have to follow ஒரு adequate biosafety biosecurity procedures follow பண்ணணும். And also like lab technicians, those who are collecting samples, they should be wearing appropriate PPE while taking the sample. So recommended PPE வந்து N95 respirators and the face shield, gloves, gown எல்லாமே போட்டுட்டு தான் இவங்க சாம்பிள் எடுக்கணும். பட் டிரான்ஸ்போர்ட்டேஷன் சமயம் வந்து you are triple packaging and send it. So there is no additional protection needed for a person who is carrying the sample in a vaccine carrier, because everything is clearly packed, biohazard marked, and it has to be safely carried to a nearby PCR facility for testing. So rapid test kits உங்களுக்கு தெரியும் இப்போ வந்து பண்ண வேணாம் அப்படின்னு சொல்லி ICMR கைடன்ஸ் கொடுத்திருக்காங்க. Unless for other surveillance purposes they are using for ELISA and other methods. But other things வந்து இப்போ rapid testல வந்து we have the Cepheid platform, அதாவது TB-ல வந்து நமக்கு CBNAT இருக்குது. CBNAT platforms is running on a trial basis in some of the facilities. Again, when you are processing those samples also, appropriate standard precautions and adequate kit should be worn while taking the sample and while processing the sample. So these are the guidelines for testing. So other panelists can jump in, and Dan, you want to add something, you can add, Dan. I'll unshare my screen. Hope the message was clear. Or sir, we can't hear you, sir. So please unmute.
I want to know one thing here is like each and every times we used to say like whenever we are seeing a different patient, we have to change the gloves. But in the collection center, the people are using the same gloves for the collecting the specimen, right?
No, they shouldn't be using that. They have to change the gloves.
Okay.
Even in the collection center, they have to perform hand hygiene.
Yeah. If they're using it in the whisk and they are using reusable gloves, those need to be disinfected between patients. So there's two things. If you're using,
what I'm asking about the fixed gloves, the yellow gloves which you are using in the,
they should be disinfected between each patient.
So ஒவ்வொரு பேஷண்ட்க்கு வந்து ஒரு 1 minute ஆது கான்டாக்ட் டைம் கொடுத்து ஹைப்போக்ளோரைட் சொல்யூஷன் வந்து ஸ்ப்ரே பண்றாங்க சார். So that's what they are doing. Like we have specifically asked to Kerala people like how you are disinfecting. They said like they are giving a contact time for at least 1 minute. They are spraying hypochlorite and they are waiting for another 5 minutes, and then only next patient is taken in. So between patients there is a time, and also disinfection is done using hypochlorite.
Suresh Valan sir, you want to add anything?
I think both the eminent speakers, Dr. Valan sir as well as Daniel, have given a very good topic. Their presentation is very good and clear, especially Danny on the various dynamics of the virus and the importance of PPE in every aspect of the healthcare provider during his daily practice, as well as the environment. Environment is a very, very important factor that has been highlighted. But one thing which he has highlighted is the secondary infection. That the SARS has got the potential to cause infection again and again. That is really an alarming thing as far as India is concerned, because now the lockdown has been released and most of the people are a bit happy that the incidents and the numbers are a little lesser when compared to the global scenario. So that's one part which we have to be always cautious about. And Dr. Valan has nicely explained about the collection of the specimens as well as the things which we have to do to prevent the healthcare providers from getting infected. It was very nice, and I should thank Dr. Sivakumar for the excellent opportunity that he has given to all the IMA doctors in our district, especially when we are all about to start our practice soon, because we have a very wide variety of doctors, right from general practitioners to super specialists. That's very, very important. Each and every one of us have got doubts in their own areas. As a pediatrician, I have my own doubt on regarding the vaccination, how to vaccine a child, whether it is safer to bring them during this scenario when we are expecting a lot of asymptomatic patients. So that's also highlighted. And thank you very much, sir, for the wonderful discussion. Thank you.
Dr. Valan, like.
Yes, sir. Okay. Yeah, so this is a very nice question, and I would like to, Dan, like you can start with US guideline. Oh, you have already mentioned about the US
We've
guideline.
already kind of gone through the US guideline.
Yeah, let me go to the Government of India guideline.
What I'm asking is like, Dr. Valan.
Yes, sir.
This is like personally by us, like if I'm infected today, like health workers, as a doctor,
yes.
if I'm infected today, when I can return back to my job. That's my question.
Okay, so yesterday there was a guideline from Ministry of Health and Family Welfare regarding this. So they are categorizing into like what was your exposure, like whether you had a high risk exposure or a low risk exposure. So high risk exposure means like you had a contact with less than 1 meter for more than 15 minutes with a patient who was COVID positive, and like you tested positive later that. So you will be sent to isolation facility. You will be treated like if you are mildly symptomatic, you can be home isolated. So as per following the Government of India guideline. So, or if you cannot be home isolated, then you will be sent to a COVID care center. This is for mildly symptomatic or asymptomatic healthcare worker who has tested positive after being in contact to a COVID positive patient. So now these, like after 14 days, your repeat test will be done. And if your test is negative, then you come back to work. So that is what the Government of India guideline, which was released yesterday. So I can share you the link in the chat box. So there is an advisory. So that very clearly mentions all these things. In case if you are like you were infected, you tested positive and you are seriously ill, you will undergo treatment and you will follow like any other patient who, as I had earlier mentioned, right? Your repeat test will be done, and when you are completely cured, then only you can return to work. So in case if you test negative, you will be monitored. So again, like you will be, if you develop any symptom, you will be monitored every day for symptoms, and there will be a nodal officer assigned at each of the healthcare facility. So these nodal officers will ensure that immediately when they become symptomatic, then they will be immediately isolated and they will be treated as any COVID positive patient, and they can return to work after 14 days when their symptoms resolve and they test negative results. So this is what the Government of India has given for healthcare workers are concerned.
Thank you.
So mild cases, asymptomatic cases, you will follow the routine course like any other patient, and you can come back to work. So other severe cases, again, you will get treated and you will get tested, and then when your test is negative, you will come back to work. But
thank you, Alan. Thank you. So, like,
if you have recovered, you won't be allowed to work in a isolated isolation ward or a ICU where COVID patients are being held. That's what they mentioned. They should be given like adaptive work to some other wards. So I have
given like thank you.
The link is shared in the chat box. Yes, sir.
Can you?
Yes, sir.
It's unable to open.
A little more explicitly say, suppose a doctor today tested positive.
Yes, sir.
And is mild. After how many days, and he will be able to see logically with a patient.
So he is like asymptomatic, and after 14 days, like there are no symptoms, and he has a repeat test has been done. He is negative. Then he can return back to work.
So 14 days.
Case to case basis. Again, this is what the Government of India guideline says.
Thank you, Alan. I think so. This question is for Dr. Jailal, because like yesterday he was present with the doctor, like our minister, health minister. What is the measure should be taken following the COVID positive in the hospital, the duration of specified for the hospital lockdown? Because the incidents which happened in KANYAKUMARI, like there was so much of rumors like which is arising, the hospital is closed, sealed and everything. So nice answer is given by health minister yesterday. I think so he can share with us like Dr. Jailal sir.
No, the government of India has also given that direction that it is only 24 hours. So the disinfection of the entire hospital has to be done with the 24 hours time. And after 24 hours, the routine work of the hospital can be started, which our health minister has also now confirmed, and he has assured that it will not be more than 24 hours.
Dr. Valan, you want to add something?
No, like the same guidelines. So this has been debated for the past 1 month, and we also provided some inputs, because initially they were shutting down all the hospitals, and this was brought to us by our honorable IMA state president also, like when we had a panel discussion with them, and like we had discussions with the Ministry of Health people also, like shutting down the hospital and like denying essential healthcare is going to disrupt the system like badly. So then they came out with this guideline. So mainly they will focus on disinfection and reopening the services for essential healthcare, and not like closing down the whole facility. So maybe part of the facility till disinfection may be closed down, but the hospital will still continue to function.
Dr. David, like this is a question for you. I think so. Like today, when the patients are coming inside each and every hospital, we are saying like you first you wash your hand, like put your hand hygiene and put a mask. What is the recommendation when the public of the patient is coming inside the hospital? What are the protective care of the choice for the public?
So for the general public, we ask them to wear what we call in the CDC a face cover. That could be, if they have a surgical mask, they can use a surgical mask. If they have a cloth, they should use a cloth. Generally the cloth cover is not fully protective. It will allow some virus to go through here, back and forth. But it will decrease the spread. There was an interesting study that looked at if I cough, even when I have a surgical mask on, if I have a cloth mask on, what happens? And what happens is that there is some virus that comes out from the sides, but it's much less. It's not going to be that projected out into the space, but it will kind of be more contained. And for that reason, and if we look at the case counts in countries that have mandatory masks and they're actually complying with those masks, the cases are the public health would be that the cases are lower, I think, because of the mask use. So we recommend that all patients have the mask.
We see like there are so many choices today. If we see like there are doctors like our health personnel working on N95 mask with a valve type, like a respirator with valve type. Are you like say this is a perfect choice for the doctors with a valve?
So
which is the best choice?
Yeah. So the surgical mask, the filtration efficacy is around 60%, 60 to 70%, and the N95 is 95%. The issue with the valve is not so much for the patient, for the provider who's wearing it. That protects the provider. But if the provider has coronavirus, they're going to breathe out coronavirus into the air. And so it's more of a risk for, if it definitely shouldn't be used for any kind of surgery procedure, because then that could seed. It shouldn't be used in close proximity to other healthcare workers or other patients, because you're going to end up having virus if the provider's infected coming out. So it's not recommended for the healthcare setting.
Thank you. Thank you. So the valve type is not acceptable for the health workers because like when you are expiring, there's a chance of viral is going out from the health worker to the patient or someone else, right?
Correct.
Thank you. Thank you very much. Like and this opportunity, like I'll say the whoever the like viewers, the doctors, they can through the chat, they can ask the question also. That will be asked to the panelist.
So because the valve is one way, it only exhales air. So if they are infected, they will be exhaling the virus.
Right. Right. Next. Do and don't for while using the respirator. Even we are like health workers when we are using when you use like see the so many medias like when there are so many publics are using a health mask, they'll be like touching their nose and other things like do's and don'ts while using the respirator.
Yeah. So, you want to take this up?
Simple question, but I think so. Like
no. The one which you are doing here in the picture should not be done. Never touch friend of mask because like this is really contraindicated what you are doing now. Like whenever you are removing also, never touch front of the mask because it is contaminated always because you are inhaling air, so that is contaminated. Never touch front of the mask and never adjust. And also, like I have seen many people, like even sorry to say, like doctor colleagues when giving press interview, they will be wearing the mask like below their nose and they will be closely standing with someone. Like us now, even like loudly talking, you can exhale the virus through droplets. So you have to be very careful. Like when you are wearing a mask, like you have to wear it like above the nose, like completely cover your nose and mouth. So otherwise there is no purpose of wearing, like mainly of our colleagues, even in hospitals, they will be wearing below their nose, which is strictly not recommended. And when it becomes wet, immediately you have wet or soiled, immediately you have to change the mask. But never, like again, the picture, what you have put it here, like never touch the mask in the front side, either doing work or while removing also. While you are removing, you have to remove it from the back, like holding the back thing, the ribbon which is in the back side, and never touch the mask in front.
Thank you, and thank you. And I think so. This opportunity,
one
Dr. Vijay Kumar, past national president of IMA headquarters, he joined with us now. Welcome you, sir. Vijay Kumar, sir. Vijay Kumar, sir.
Sorry for the delay. I was conducting a Zoom meeting for the Rotary India Health Mission. Sorry.
No problem, sir.
Only
Please.
it is finished. Thank you. Thank you for calling.
Like there is some comments like because like nowadays like you can see unavailability of the mask now. Like if you want to go for a 3M mask or something, like even we are getting duplicate mask, or like sometimes we are getting a mask but like it's a limited quantity. Can we recommend the reuse of the respirator using the consistency and the crisis capacity strike? Balan.
Sir, can you please give me permission to share my screen?
Please carry on.
Can you see my screen, sir?
No, not it.
Now?
No. Yeah.
You should. Yeah. Okay. So first, like I request Dan also to add like immediately after I go through the initial few slides about the different methodologies and take over to explain each methods. So first வந்து நம்ம ஹாஸ்பிட்டல்ல என்ன பண்ணணும்னா நம்ம PPE ஓட burn rate எவ்வளவு, ஸோ இதுக்கு வந்து நம்ம வந்து அதை கால்குலேட் பண்ணணும் எவ்வளவு நமக்கு தேவை. ஸோ எவ்வளவு PPE நம்மள்ட்ட இருக்குது, எவ்வளவு நமக்கு தேவைன்னு சொல்லி நம்ம வந்து கால்குலேட் பண்ணணும். There are very simple calculators available from WHO and also from CDC. CDC one is little bit complicated, but WHO one is very very simple. So இதோட லிங்க்ஸ் இருக்கு, இந்த ஸ்லைட்ஸ் எல்லாம் உங்களுக்கு கண்டிப்பா ஷேர் பண்ணுவோம். ஸோ உங்கள்ட்ட இருக்கிற குவான்டிட்டி இப்போ எவ்ரி டே யூசேஜ் எவ்வளவு இருக்குது நீங்க அதுல போட்டீங்கன்னா எவ்வளவு நாளைக்கு வரும், எவ்வளவு PPE உங்கள்ட்ட தேவை இருக்கும்னு சொல்றது வந்து நீங்க வந்து இதுல வந்து ப்ரொஜெக்ஷன் வந்து உங்களுக்கு கிளியரா கொடுக்கும். So இது மட்டும் இல்லாம PPE எல்லா இடத்துலயும் ஷார்டேஜ் இருக்குது. Now government has taken lot of initiatives that is being replenished, but the problem is lot of fake PPEs are also coming into market. அது உங்களுக்கு தெரியும். So கரெக்டான PPEs நீங்க வாங்கி யூஸ் பண்றது still challenge இருக்கலாம். So இதுக்கு வந்து மெயினா வந்து என்ன பண்ணலாம்னா சில ஸ்ட்ராட்டஜிஸ் ஃபாலோ பண்ணி PPE மினிமைஸ் பண்ணலாம். So என்னன்னா வந்து டெலிமெடிசின் பண்றதுனால நம்ம வந்து பேஷண்ட் இன்டராக்ஷன் கம்மியாகுது, இந்த PPE யூசேஜ் வந்து கம்மியாகும். பிசிக்கல் பேரியர்ஸ் நம்ம ஆல்ரெடி சொன்ன மாதிரி அந்த டெஸ்டிங்கே வந்து அந்த விஸ்க் யூஸ் பண்ணும்போது உள்ளவங்க மாஸ்க் போட்டுட்டு உட்காந்துட்டா போதும், ஏன்னா ஃபுல்லா வந்து அவங்க ப்ரொடெக்டடா இருக்காங்க. அதே மாதிரி ரெஜிஸ்ட்ரேஷன் டெஸ்க்ல உள்ள ஸ்டாஃபுக்கு வந்து எல்லாருக்கும் நீங்க PPE கொடுக்க தேவையில்லை. ஒரு கிளாஸ் பேரியர் நம்ம வந்து வச்சிருந்தோம்னா so that will protect them from the patient or pre-screening ஏரியால உள்ள பேஷண்ட் வந்து ப்ரொடெக்ட் அவங்கள்ட்ட இருந்து இந்த இன்ஃபெக்ஷன் வர்றதை ப்ரொடெக்ட் பண்ணும் ஹெல்த் கேர் ஸ்டாஃபுக்கு. ஸோ அதே மாதிரி இப்போ டைரக்டா கோவிட் பேஷண்ட் நான் கோவிட் பேஷண்ட் பிரிச்சு நான் கோவிட்க்கு வந்து லைக் மினிமல் PPE and கோவிட் பேஷண்ட் ஏரோசால் ப்ரொசீஜர் இன்வால்வ் இருக்கிற பேஷண்ட்ஸ் ஃபார் கேஷுவாலிட்டி ஆர் இன்டுபேஷன் ஏரியா இங்க இருக்கிறவங்களுக்கு N95 ரெஸ்பிரேட்டர் மாதிரி. ஸோ இந்த மாதிரி வந்து நீங்க ரேஷனலைஸ் பண்ணிக்கலாம். ஸோ அதே மாதிரி ப்ராப்பரா ஃபோர்காஸ்ட் பண்ணணும், எவ்வளவு யூஸ் ஆகுது அப்படின்னு சொல்லி நீங்க பார்க்கணும். இன்னொன்று வந்து நிறைய தெஃப்ட் கூட நடக்கலாம், நிறைய பேர் வந்து எடுத்துட்டு போயிருவாங்க வீட்டுக்கு. ஸோ இதெல்லாம் க்ளோஸா வந்து மானிட்டர் பண்ணணும். ஸோ இதுக்கு வந்து இந்த நம்ம ஆல்ரெடி வந்து அந்த கால்குலேட்டர்லாம் இருக்கிறத நம்ம யூஸ் பண்ணா ஈஸியா வந்து நமக்கு வந்து கண்டுபிடிக்க முடியும். ஸோ இன்னொரு முக்கியமான இது வந்து பாத்தீங்கன்னா வந்து ஸோ நம்ம டான் ஆல்ரெடி வந்து மென்ஷன் பண்ணியிருந்தாப்ல SARS வைரஸ் வந்து up to 72 hours வந்து it can stay in plastic or stainless steel or cardboard surfaces. இப்போ N95 ரெஸ்பிரேட்டர் பாத்தீங்கன்னா இந்த மிக்ஸ் ஆஃப் ஆல் திஸ் மெட்டீரியல்ஸ் தான் பண்ணிருப்பாங்க. ஸோ லைட்டா ஸ்டீலும் இருக்கும் அந்த பெண்ட் பண்ற இடத்துல, நோஸ் பெண்ட் பண்ணி ஃபிக்ஸ் பண்ற இடத்துல. ஸோ இது எல்லா மெட்டீரியலும் இருக்கும். ஸோ இப்போ சில ஹாஸ்பிட்டல்ஸ்ல என்ன பண்றாங்கன்னா 5 N95 ரெஸ்பிரேட்டர் ஈச் ஹெல்த் கேர் ஒர்க்கர்ஸ் கொடுத்துட்டு ஸோ எவ்ரி ஒர்க்கர் வந்துட்டு ஒரு இது வந்து போடுவாங்க எவ்ரி டே. ஸோ அதுக்கு பிறகு ஷிஃப்ட்டுக்கு இது பண்ணி ஆஃப்டர் 5 days they will be reusing it after that. So இதுக்கு வந்து யூஎஸ்ல வந்து என்ன பண்ணுங்க, like Dan, you want to comment on like what they do in US? So then I'll take over. So Dan, are you there?
Yeah, so in the US, the not every hospital, but this particular hospital in Nebraska used paper bags. We know that the virus can't exist on the metal, plastic, and kind of the paper for more than 72 hours. So we use that fact to say, if we just let the mask sit for 72 hours and don't touch it, and we put it in a brown paper bag, which absorbs the moisture, the virus should die. And then we can reuse the mask safely. Now, this also applies to other PPE. So here they have face shields that they've cleaned with either alcohol or chlorine, and then they've set it. Now, the face shields are a little bit harder because you can't really clean that foam very well. So leaving it sit for 5 days allows it to be reused. This is not optimal. You'd rather have a new N95, but in the setting where you don't, you can reuse it after that period. And I know that AIMS has an actual video on how they reprocess, and they give everyone 5 masks, and then they ask after they use the last mask, they use the first mask, and after 20 days, then they give them new masks. So the masks too, they can't use them forever. So there's situations where you can't use the mask. So if you're using it for an aerosolized generating procedure, the mask is considered highly contaminated, and you should change the mask. If it has blood, if it gets wet, you shouldn't use it. And there's also, this indication, like if I go see a patient that's on contact precautions that has C. diff or they have MRSA, really it's not optimal that you reuse the mask. And of course, if it doesn't fit, it's no longer an N95 mask, and breathing is an issue. So some specific precautions, and Vulin went through some of these precautions when he was talking about touching the mask. But in reusing the mask, if you're going to touch the mask, you should always wash your hands before and after, and you shouldn't touch the inside. And then making sure that it's not, the integrity of the mask is not compromised.
இன்னொரு விஷயம் வந்து மாஸ்க் யூஸ் பண்றதுல N95 ரெஸ்பிரேட்டர்ஸ் எல்லாம் வந்து நீங்க வந்து எக்ஸ்டெண்டட் யூஸ் பண்ணலாம். ஸோ என்னன்னா வந்து சிடிசி கரண்ட் ரெக்கமெண்டேஷன் வந்துட்டு என்ன சொல்றாங்கன்னா அப் டு 8 hours வந்து நீங்க வந்து எக்ஸ்டெண்டட் யூஸ் வந்து சேம் மாஸ்க்கை வந்து யூஸ் பண்ணிக்கலாம். பட் இன்கேஸ் அது வந்து சாயில் ஆயிருந்தாலோ இல்லது வந்து வெட்டா இருந்தாலோ இல்லது ரொம்ப காத்து வந்து உங்களுக்கு சுவாசிக்க முடியாம இருந்தாலோ ஆர் if it is not fitting கரெக்டா ஃபிட் ஆகாம லூசா வருதுனாலோ ஸ்ட்ரிக்ட் அது கிளியரா ஃபிட் ஆகலைன்னா immediately you have to change. So otherwise, like if you are not engaged in any aerosol generating procedure, it is not soil, it is not wet, so then you can use it up to 8 hours continuously. So even though WHO வந்து என்ன சொல்றாங்கன்னா like most of the circumstances 4 மணி நேரத்துக்கு மேல நீங்க யூஸ் பண்ணீங்கன்னா ரொம்ப uncomfortable இருக்கும். But when you feel uncomfortable, immediately you have to change. But 8 மணி நேரம் வரைக்கும் வந்து same N95 respirators யூஸ் பண்ணலாம். That is what CDC recommends. So இது ஆல்ரெடி வந்து நம்ம வந்து டிஸ்கஸ் பண்ணிட்டோம். So ministry, okay. So இதுல வந்து சில methods like Dan will be briefing about each and every method நான் சொல்றேன். So periodic reuse already நம்ம டிஸ்கஸ் பண்ணிருக்கோம். என்னன்னா வந்து 5 மாஸ்க் கொடுத்துட்டு 5வது மாஸ்க் ஃபர்ஸ்ட் டே யூஸ் பண்ற மாஸ்க் அடுத்த வாரம் வந்து நம்ம வந்து யூஸ் பண்ணுவோம். So that is one of the method. But again, you should not have used that mask in any aerosol generating procedure. இன்னொரு விஷயம், it should not have been contaminated and should not be problematic for fitters. So இந்த மாதிரி இல்லைன்னா then you can use. So other promising methods வந்து பாத்தீங்கன்னா ultraviolet radiation, hydrogen peroxide vapor, like this is widely used in many of the health facilities including All India Institute of Medical Sciences. So moist heat use பண்ணலாம், steam sterilization and liquid hydrogen peroxide. So these are some promising methods. So இன்னொரு சில methods வந்து they are very promising but lot of health hazard to people, like ethylene oxide வந்து ரொம்ப promising method, but when you use like it is carcinogenic and people may end up having cancer if they use it. So this is not recommended due to the health hazards of this. So where are the other methods which is currently under study which is not recommended is autoclaving பண்ணக்கூடாது, isopropyl alcohol again use பண்ணக்கூடாது, soap, dry microwave, again dry microwave new guidelines have come. So Dan will be briefing on that, and chlorine bleach should not be used. Soap, alcohol, autoclave should not be used. Dry microwave, like some new guidance have come, and over to Dan for explaining like each of the method. Should I start from here, Dan?
Yeah, that's fine.
Yeah.
So,
Dr. Daniel,
yes.
before going for the next topic, I think so Dr. Scott has some question for Daniel. Dr. Scott? Dr. Scott?
Yes. Yeah. Good evening, everyone. Thing is, Dr. Dan, you mentioned about this spillage of this aerosol on the mask as well as on the face shield. There is a study which has mentioned, and all it spills all over the face, neck, and everywhere when anesthetist intubate a patient. So what's the take on it? How to prevent this in spite of the PPE? I mean, how do you?
Yeah, so that study was a very small study that showed that, you know, the people that were wearing goggles and mask and gown, they still got some droplets on like their ears or on their neck and on exposed skin. And so if you are doing perfect PPE and those are areas that are exposed, if you touch that and then touch your eyes or nose, then you self-contaminate. And so, you know, when you're doing those procedures, you have to be very careful. You know, some hospitals have moved to showering after, and there's some guidance that, some very nice guidance from New Zealand on how to protect yourself. As soon as you get home, you shower and that you wash so that you don't self-contaminate. So I think it's just, and this is where, you know, some of the workers have gone for like the full headgear so that they don't have any exposed areas. If they're working in a high contaminated environment with aerosolization, it's in order to protect those areas that maybe that they miss. So that would be the implication. So again, that was a small study, but it did show that there were some areas that were not covered that could be contaminated.
Thank you, Dan. Thank you, sir.
So as far as reuse of masks, so this, you know, we know that droplets can land on masks. What's the risk for us when we're using masks? So this was a very small study out of Singapore where they were taking healthcare workers when they came out of the rooms, the 15 patients with coronavirus, and then they were checking the masks and they couldn't find virus on the masks. Again, this is a small study. This was done in rooms that had very good air exchanges, and this was not when they were doing an aerosolized generating procedure. But to say that in the normal course, if you're just going in and out of rooms, you may have some, but it may not be as much as you think that is on the N95. But of course, you can't take this as, I don't have to follow my precautions and don't touch the mask. I'm just saying that, you know, it's a study. Next. So some have also said, if I wear a mask over that N95, that might help prolong the life, and also a face shield. So if I have a face shield, then it protects the mask as well, because the droplets end up on the face shield. And some healthcare workers find that if they wear a surgical mask and a face shield, they're able to go longer and it's more comfortable for them for long-term, care. As far as heat sterilization, we know that the virus can't survive over 65 degrees. And so there's protocols where 65 to 70 degrees for 30 minutes, and then the mask can be reused. For this particular methodology, I've just seen it used twice, and then the mask has to be discarded. Next. If we're looking at steam sterilization, again, this is you're using high temperature to kill the virus. There is a little bit of loss of the filtration efficacy, but still not too bad. A limited evidence, and again, most of these methodologies is very limited evidence for their reuse. And maybe, Volin, what we can do is post in the chat the CDC website that summarizes a lot of this guidance as well. As far as UV light radiation,
the upcoming slides. It's there.
Okay. So in as far as UV light, there's protocols. There's one out of University of Nebraska. I think if you have UV light or gamma rays, I think you have to be careful because some of those are different than others. So what do you use? How close does it go? It does damage the material in the mask. I think you have to kind of be very savvy and scientific about how you use radiation and UV. Next.
Sir, can I ask a question?
Sure.
Yes, sir. Please go ahead, sir.
Yes, sir. Can you see my, 1 second.
You want to share something?
Yeah, sure. Can you see my mask hanging, sir? Is it okay?
Yes.
So, you know, hanging the masks out is really the same methodology. You're just trying to get rid of the virus by putting an environment that is dry, that doesn't allow it to grow, and on those surfaces, which is metal, paper, cardboard-ish, and plastic, 72 hours, you should be able to reuse it.
And we do have coded with number one and number two. This is number 2 and number 3 and number 4. So like come for a round of 5 days, and I've been using it for now nearly a month.
But
that's right or wrong, that's what I'm trying.
No, this is fine, but only issue is where you are hanging, in your cabin inside the hospital, or you are hanging, because other people shouldn't touch and shouldn't use, like, kids and all should not touch the friend. On day 1, there may be still some virus, so you have to be really careful.
Keep it in a safe place. Understand that.
Okay.
Thank you, sir.
That is very good.
That then you have to look and see how long it actually fits as an N95.
Yes.
Once it doesn't fit as an N95, then you have to use it.
Thank you, sir.
You have to do the fit test before, like after every every reuse. Dan, you want me to proceed, or you
Yeah,
can?
so as far as alcohol and chlorine, not recommended. It really decreases the filtration efficacy. Chlorine is additionally something that is irritating. So both of them affect that electrostatic charge in the N95. Ethylene oxide, a definite no. It's a definite no because it's toxic. It can cause cancer and should not be used. I think we went over some of these slides. Nitrogen peroxide, also.
This is liquid, and promising methods are hydrogen peroxide vapor. So there is a very promising results like when they use hydrogen peroxide vapor, and they can use up to 4 to 5 times. Am I correct, Dan? Like that's what CDC recommends.
Yeah.
Yeah. So UV already we discussed, and this is the guideline that Dan was mentioning. This is available. So when these slides are available with you for different types of method, what is the efficacy after use and how many times you can reuse. So all those things are available in this website from CDC.
It has the protocol of how you process the masks and the references. You'll notice that there's very few references, but it has the protocol, and there's different protocols for the different methods. So just go to the website. It's something that instead of the slides I would refer you to because things change. But the protocols are there.
Update this. So, most important thing is, I would like to mention here, there are a lot of fake products available in the market. So these are some of the fake products identified by the NIOSH, and they have put it in the website, which should not be used. So they don't have NIOSH approval. So there are different bodies to give approval in India, but beware, like you can visit the website and find like some of the counterfeit product of N95, which is in the market, like all over the world. So Dr. Sivakumar, hope I have covered along with the great support of Dan about reuse of mask, and reuse of mask should be considered when there is non-availability of like adequate quantity of stocks. So you can use a burn rate calculator, and if you don't have adequate supplies, then you can think about reusing the masks. If you have adequate supply, so you can use single use.
Yes, nicely answered. Next, I think so. Like there is our gynecologist and obstetrician, senior obstetrician here, Dr. Chitra Madam. Dr. Chitra Madam, please. Dr. Chitra Madam.
Audible?
Hello.
Hello.
Madam, if you have any doubts, you can ask it, Madam. And as well as for the public, we had a consideration for the inpatient obstetric healthcare setting for the COVID positive mother. We asked the question, even you can answer, or like if you want to put forward some other question also, you can forward.
I have a question. Am I audible, sir?
Yes, madam.
Hello.
Yes, madam.
Yes, ma'am, you are audible.
Yeah. So they say we have to have a negative pressure in the theater. Is it mandatory, sir? Because most of the theaters, we don't have negative pressure.
As far as a negative pressure for positive patients. So the answer is that, it's optimal that you have negative pressure, but we realize that many facilities may not, or you have so many patients that you don't. So you want to put them in wards that have good ventilation and that have good airflow, that move air away from the patient, from staff, as well as non-COVID patients. And there's some nice guidance on ventilation.
Can you please give permission to share the slides so that Dan, I can share the slides and Dan will be explaining about air exchanges. So yeah, thank you. Can you see my slides?
It's coming.
Okay.
So if you look at ventilation, and we often get this question.
Full screen, please.
Yeah, sure.
Is what's adequate ventilation? So in some of the older hospitals, ventilation is 6 air exchanges per hour. There's calculations that you can use to determine ventilation. And then there's some, the next slide. There's a venometer that you can use to measure the speed. And in this example, this is very simple. So if you have a door and a window and you keep them both closed, you're not going to have any air exchange. If you open the window and keep the door closed, the air exchange is only 4, and really you'd like 12. If you open the door and the window, your air exchange goes up to 37. So very simple use of windows and doors to increase your air exchange. And in wards that have coronavirus patients, you do want to have good airflow, but you have to watch where the airflow is going, of course.
Daniel,
yeah, sorry, Dan.
I want to add on something here.
Yes,
about talking about the ventilation as a surgeon, like we are like so many surgeons also here. How they are doing a surgery nowadays, it's not advisable. Something is not advisable is like when you are having a split AC, like inside the OT or something. Like advisable, like which can be the mandatory is like nowadays is like laminar flow, which can be filtered 0.3 micron of like particles one. Then we were using a positive pressure OT technique still now. But nowadays, what for the COVID thing, what we are advising is a negative pressure OT. Like the OT has to be suck the air from outside. Like what we are using before is the pressure which will, like when you are opening the door, the air will push you outside. Such a positive pressure will be having one. Now what we need is a negative pressure because the aerosol which we are going to create by the cautery or like diathermy, which is going to be harmful to you. One. Then how we are going to come out of this like aerosol thing. That second question will be arising from even each and every surgeon. I think so. Like in the last, like I will demonstrate how we can avoid the aerosol from the cautery thing. Cautery induce the aerosol. Thank you. Carry on, please.
Yeah, and yeah, like there is a specific guidelines for air conditioning also from the Central Public Works Department. Like I think we can share that guidance also. So which recommend like how in operation theaters and all, like you can manage the airflow by following certain steps, like, and what filters you can use if you are using a centralized air conditioning system where the air is taken outside and by using a separate duct and pushing it through the chemical or ultraviolet filters and all, no, like other than HEPA filters, because HEPA filters not always filter 0.3 microns and all. So so there are some recommendations which we can share with you and you can go through, because you people know the best what is required for the operation theaters.
Sir, can I ask a few questions, sir?
Yes, sir. Please, sir.
Yeah, one to Dr. Valan. Sir, in Tamil Nadu, the prevalence seems to be very less, because when you see the number of test positive, it is very less. Out of some 2 lakh specimens we have tested, it has come like 10,000 only is positive. So how do you take it up? Whether the prevalence is very less in the population or we are going on the wrong method which we are following? And what is the message we give to a person who is tested negative? That is one thing. And to Danny, I want to ask a question. What is the recommendation for the usage of mask among children?
Okay. So let me take up the first question. So like, I don't know like what strategies they are following in Tamil Nadu, but they hope they will be following the Government of India guidelines for like symptomatics and SARI patients. All those things will be followed, and also healthcare providers who are into contact with the COVID suspected or confirmed cases and people from the hotspot. So these might be the guidelines they are following. Like when they are using extensive testing strategy, like definitely the number of tests going to be positive will be less. So it is very too early, I would say, to say about the prevalence or the case fatality rate now, because the infection is still, the outbreak is still ongoing and different clusters are being identified. So like if you ask me this, are we testing the wrong people? I don't think so. They will be testing the right people only, but it is too early to comment on the prevalence or like incidents of cases coming now when an outbreak is still ongoing. We cannot comment on prevalence at all. So second thing is you were asking about like what should be done, like if patient is negative, what should be done. So see, if you do PCR also, the sensitivity is around 70% only. In 30% of the cases, you can still get a negative. And if you test early during the infection, so they may still, because PCR turns out positive, the chances of turning out positive will be after 3 or 4 days, the chances becomes more and more. And after 9 days, it like slowly vanishes, you know. So what happens here is, so if you test too early or too late, the PCR can still be negative. But again, if you ask like too early during the pre-symptomatic phase, they can still be infective. When they talk loudly or when they cough or sneeze, they can still spread the infection, even though the PCR might come negative. So there are chances that they can still be infective. So in this scenario, definitely like overall public masking, avoiding crowded areas, social distancing measures, this will help to prevent the transmission. And regarding people getting tested negative after 9 days, but like the chances of infectivity is much less in the community. You know, the viability of the virus in these patients are like considered to be very low. Dan has showed those studies which mentions that after 9 days, like there were 0 virus cultures could be made from the infected patients. So again, like this also gives a message that there are less chances, but there may be some patients who may still be infective. Like there are like remote chances they may still spread infection, but most of them won't spread any infection because the virus particles may be there, but the virus won't be viable.
One observation in Kanyakumari Medical College,
yes,
that
sir.
The SARI cases and ILA cases where we have done tests, most of them are negative.
Okay, sir, what I would suggest is you have to revisit how the sample is being taken. This is very important. Whether the right medium and like check the expiry date of the viral transport medium, because you will be testing it immediately, but still, so you test all the mediums and all taking how he is taking, because you, and as I had mentioned you, if you put both nasopharyngeal and oropharyngeal together and then test it, the yield will be more. And when you are testing, and how is your lab, are they putting the controls and all properly, and whether controls are coming correctly, all those things has to be taken into consideration. But again, if it is a SARI case and he's a very severe case, you can still consider a lower respiratory tract sample like BAL or tracheal aspirate. All those things can be considered, and these samples can also be tested like to confirm, you know, not only limiting to nasopharyngeal or oropharyngeal thing, because the chances of getting a positive PCR in a lower respiratory tract in severe cases are more high.
Thank you, sir. Thank you. The next question to Danny, sir.
Yeah, so the question what should you do with children? And I think that children are harder because they don't want to wear the mask, or they're take it off, or they scream, but they can still transmit. And so in a clinic setting, I think that can be very challenging, because if you have children who are coming with a cough or fever, or even asymptomatic cases of COVID, they could transmit it to your healthcare worker staff, to patients that are in the waiting room. And so you have to try to get them to use the mask, but then you have to take precautions to avoid getting contaminated by a child. But children can transmit it just as well as adults.
Madam?
Yes, sir. Please.
Like, so in your side, like any slides are left over? Like,
no, we have, like, you, if there are questions, we are happy to answer. So if there are questions from the participants, like we are happy to take, or from the panelists, we are happy to take and answer.
Sir.
Yes, sir.
Doctor, like our pediatrician, as well as like cinema specimen in our IME. Thank you, sir.
Sir, I am a pediatrician, but I have a question to Dr. Valan. Sir,
Yes, sir.
once you deliver a COVID positive mother and the child is normal and I'm taking the child to the ICU and keeping to the ICU. So whether the child should be kept separated till the mother is also discharged, or because yesterday during the meeting also health minister said that in Kadalur he appreciated the work of the staff there where COVID positive mother was delivered, and with the mother with N95 they have breastfed the child successfully.
Yeah.
So what is the current recommendation, and do they have a separate NICU for COVID positive mother babies?
No, sir. So what the current recommendation from WHO and Government of India and also CDC also, like you have to discuss all this pros and cons with the mother and give the mask to the mother and breastfeed. So Ministry of Guidelines are very clear, like successfully use the mask to breastfeed, because so currently the transplacental transmission or during deliveries, like the chances of getting the child getting infection is very, very limited. We don't have much evidence, but there are anecdotal reports that the child getting tested on day 1 of birth and all, like there are anecdotal reports here and there coming from India and other countries. But mostly, like most of the studies have told that it is very, very minimal. But by providing a mask to the mother, you can continue breastfeeding and kangaroo care, like everything can be given, because like when the mother, like, and also WHO recommends like properly cleaning the breast and all, because like if she coughs or something, the droplets maybe still be present and she can transmit the child. So always the mother should be wearing a face mask, and like breastfeeding is recommended, sir. Like that's what WHO and national guidelines also recommend. So Dan, do you want to cover these guidelines?
No, I think that, you know, what you've said is accurate. And I think that there's a lot of work that is going to be done around pregnancy, around these specific scenarios. I know to kind of go from the male side, there's also been several studies around semen, and one small study didn't find coronavirus in semen. Another one found coronavirus in the semen by PCR. That doesn't mean it's infective yet. So there's no evidence of sexual transmission of COVID. But if it was, then that could be a whole other public health implication, like it was in Ebola. But so far, you know, more evidence needs to be done in both women and for men from the reproductive side.
Thank you, sir.
Thank you. Dr. Jairal, sir, a question for you from Dr. Madhavan Pillai, sir, the senior motor anesthetist. Like if the anesthetist is going to give anesthesia for the patient who may be like diagnosed as a COVID positive after the surgery, if the surgeon as well as the anesthetist, even though they are using a PPE, they should be quarantined or not? Question is.
Now the guidelines is, if you are using adequate PPE, there is no need for a quarantine. And if you are not confident that you are used adequate PPE at the time of exposure with the evidence of as per the standard protocol, then only you are supposed to go. See, in the COVID positive ward, and we doctors are working, and every day we are getting exposed to the COVID positive patients. And that means we are not getting quarantined fully. Continuously we are working. So there is no recommendation that if you are using adequate PPE, there is no need for quarantine. If you are not used, I'm sure you have to go for a quarantine as a contact history.
So, yeah, I'll take this. So, you know,
Dr. Alfonso Patrick as well as Dr. John Titus. Does the nutrition play the part of preventing the spread of COVID-19 in new personals? One, anything like a link between the vitamin D deficiency between the COVID-19?
So, what was the first question, sir? Second is vitamin D. The first question.
First question: nutrition play the part, like any part in the preventing the spread of the COVID-19?
Sir, like if you are healthy and if you are like more healthy, if you have adequate nutrition, any infection, like so most of the people, around 80% are mildly or asymptomatic. If you are healthy, you are not going to get a moderate or severe illness, you know. So this is for any illness. Like this is a viral illness and coronavirus was there. This is a new type of coronavirus which has been identified in 2019. But there are other viruses also. So if you are all like even flu, if you take, if you are like healthy, you are not going to have like very severe symptoms. So same has happened. But where there is a direct link between nutrition and things like that, we don't know. So what we know is when there is a comorbidity or immunocompromised state, then the severity will be more. Or when you are more than 60 years, the severity. So directly linking to nutrition, there are no studies, but we believe that because 80% of the people who get infection are mild or asymptomatic, so we assume that maybe if you are healthy, you don't get the severe disease. So that is one thing. And regarding vitamin D, there are few articles linking vitamin D and COVID. But again, like it's not in a broad scale, so still more evidence is awaited. Dan, if you know any new evidence than the small like.
Yeah, I don't know any new ones, and I think that, you know, I think we have to be very careful with these small studies, because on a random chance you can have many things associated with coronavirus that have actually nothing to do with coronavirus. And so if there's a theory behind it, you know, we can consider it, but it really needs detailed study to actually prove it. So I always am, you know, curious and say there's, you know, maybe there's a theoretical basis to it, but really need a lot more evidence to say that nutrition and COVID are related.
Well, and I mean, a few things. And one of the complications now we face this COVID era is unpeer-based article, research articles. There is
Yes,
no
sir. It is infodemic, sir.
Without any standard protocol. That is one.
Yes, exactly.
To you, well, as an epidemiologist, what is your take on the our herd immunity? Because there's a lot of controversy is going on.
No, a lot of controversy. Sir, herd immunity, definitely it is going to, sir, like if you see the epidemic curve, like when you develop herd immunity, there won't be anybody, like the virus need a host, right? So there won't be anyone for the virus to like infect. So this will be achieved when you have more than 50% of the population either achieve herd immunity using vaccine or by infection and developing antibodies. What we don't know in the current scenario is people do develop antibodies, but how long this antibodies will sustain, we don't. And also, if you want to go and infect, like prevent the old age people from going out and allow the young people go around and infect, the problem is still many people will fall sick. Our health system will be overwhelmed with lot of patients coming in. You need a lot of ventilators, ICUs, like, and healthcare professionals to care for them. So are we prepared for that? I don't think like we are, not any country is prepared for that, to let the people get sick and then develop immunity. So we are not ready for that, and it will be at the cost of so many people dying also, sir. So vaccines will be an option, but again, some are there are positive reports coming from many countries, but again, it may prove to be efficacious, but the problem is it has to establish safety in humans, and a lot of other steps has to be gone through. So it is going to take time. It's not going to be in next few months, at least, you know, like it may take at least a year or so. People are trying to fast forward things to get it quickly done, because if you test also, no, FDA has quickly approved. Usually they don't do it. So they worked very hard to approve a lot of tests in a quick time period. So same thing will happen for vaccine also, but again, it's not going to come in like in next 1 or 2 months. Like it may take some time, because efficacy both has to be established for the humans, you know. So it.
Sir, I got
again,
one
like,
question, sir.
Unless. Yes, sir. Please, sir.
Sir, one question to Dr. Daniel. Sir, how many, do you have any data on patients being COVID positive and got operated? And how was their post-operative period? Any emergency surgeries, fractures, anybody who was COVID positive and got operated, how was their post-operative recovery? Did they get into more complications than normal patients who go through a surgery? Those COVID positive patients, if they come with a surgical problem, how do you deal it? Do you have any data on it? First one. Sir, Balan sir, one more question for you is, sir, we are talking about immune boosters, keeping your immunity much better and all those things. But for me, what I always thought about is the cytokine storm is what killing people, which is overwhelming, action of our
Immune
own
response.
immunity.
Yes.
That is what is killing us. Rather than if you improve immunity to 10 times more, the cytokine storm may be 10 times more worse.
Yeah, no, you are right, sir. But the thing is, like, when you are immunocompromised and you have the disease, the severity of disease is more. That's what I meant. So mainly, if you are HIV infected or you are a patient who is on immunosuppressants, like these patients, there are chances of having more morbid conditions and go for more morbidity. Like that's what I meant. Even diabetes and all. No, if you have comorbid conditions and suppressed immunity, the severity of illness will be more. That's what I meant, and not regarding like boosting your immunity by doing something extra.
Government is advising a lot of immunoboosters, but
yeah,
the cytokine storm is you need immunosuppressant. Now the treatment for COVID disease, severe COVID disease is immunosuppressants, what they are prescribing now. We are trying to suppress the immunity when you are having a severe COVID fever and you are in the ventilator. All those later drugs are immunosuppressants.
Yes. So I agree with you, sir. Many places they use monoclonal antibodies and successfully treat like patients in ICU, and they come out very well after treating with monoclonal antibody. I completely agree with you. But these are the decisions taken at the highest level in the ministry, and yeah, we all agree that the guidance should be evidence-based. So that's what Dan has mentioned. Like sometimes people take decisions on small studies, like which may prove wrong. You know, you have to wait for the right scientific evidence to come. Same thing with Dan. I would like to tell about the chloroquine also. So like currently there is no evidence. We don't know whether chloroquine works or not, but it is being widely prescribed in some of the places, but again, like we still have to wait for evidence to come.
But there is no evidence saying the cytokine storm is related to the immunity. Even a patient who is immunocompromised can get cytokine storm. It is not proportionately equivalent. Only when your immunity is good, you will get a cytokine storm. It is out of the CIRS and CASA. They are developing that. There is no direct link between the per se your immunity and cytokine storm which is developed.
So to answer the question about post-operative and outcomes. So one thing is that many surgeries were canceled because of coronavirus. So all elective surgeries were canceled in many countries, as well as surgeries kind of being postponed. So I have not seen any data on post-operative course from surgery. And I think that's maybe because a lot of surgeries were not done. I would assume just that they would follow a post-operative course based on the coronavirus that they have and their immunity. I think that the more cases that you see in a community, that if they have a surgery, there could be a case where they have coronavirus, they have a surgery, it wasn't detected, and then they have it, which is why a lot of surgeons are asking for coronavirus testing before they do an operation, because they don't want to end up with the complications. So many hospitals that I'm aware of have a protocol where they're bringing patients in, they're testing for the coronavirus, and only if it's negative, then they're doing the surgery, because they don't want any complications that are outside what is already a potentially complicated surgery. So I don't have any evidence, but I think that a lot of surgeons are very cautious about who they're operating on and doing testing prior to doing surgery.
There is a lot of LSCS were done for the COVID positive mothers. and there was no postoperatively, there was no exaggeration of any postoperative conditions. And in Tirunelveli Medical College also, we operated on 2 patients and COVID positive for appendicectomy. And postoperative was almost no problem as we could see. But there is no, I'm not sure there is a scientific study, but personally, there is, as per Tamil Nadu evidence, there is no evidence to say that there is
disadvantage of having COVID, which will hamper their prognosis.
And in the population, pregnant women is a fairly low risk group compared to a higher age group as well. So, and again, I think that if we want to understand this, you'd have to do a study across many centers to try to understand if there's complications. As far as the hydrochloroquine question. So the hydrochloroquine has a theoretical basis. And so in the laboratory, if you look at in vivo studies, it has an effect on coronavirus. And so that's why it was said, okay, well, it should kind of work. And that's why they went to testing. The French study that was widely publicized had severe methodological flaws to it. And so that particular study, the randomization of those who got hydroxychloroquine and those who didn't was not really random. It was those that refused the hydrochloroquine. There are also, these are the slides. So we know that hydrochloroquine is relatively cheap. It's, side effects are bearable for the most part, but there are deaths associated with hydrochloroquine. Next slide. Yeah, so this is the in vivo study. So in the laboratory, it could have been effective and said, okay, so next slide.
Oh, in vitro, it was very effective to kill the virus, but in vivo, like most of the studies mentioned that it's, and as mentioned, like the French study had a lot of methodological flaws, so that cannot be taken into account. So other studies also didn't prove in vivo effectiveness of hydroxychloroquine. So that can tell about other diseases.
Yeah, so if we look at the history of hydroxychloroquine against viruses as kind of an efficacy, from the late 1960s, it's been tried. If you look at influenza, it's not effective. If you look at dengue, not effective. If you look at Ebola, not effective. Nipah, influenza, not really effective. And then if you look at hydroxychloroquine for chikungunya, maybe it makes people worse. If you look at HIV, where it's been tried, or hepatitis, it's not been shown to be effective and recommended as a treatment. So you have many viruses where it's been tried, but it hasn't been effective. And like we were talking about this small study in France, a lot of methodological flaws. So in the treatment arm, there were a death in ICU patients who were not included in the outcome. So you had, I think, 4 patients in a study that was very small that was not included in your denominator. So that could have really swung the study. And then the VA study in the United States showed really no difference. And many studies are kind of in process, and we'll see what they show. But I think from what I'm hearing is that it's not really something that's been proven to be effective, even though initially there was a theory behind it.
Dr. Valan?
Yes, sir.
There is a question for you. The merits and demerits of pooling of sample in RT-PCR, because in a PHC or in a GH setup, they are waiting for pooling of at least 25 samples to get over. So this is a question what are the merits and demerits on this? Can you explain?
So I am not a lab person. So for surveillance purpose, as an epidemiologist, I can answer this. For surveillance purpose, it is very helpful. For individual clinical purpose, it has got very major limitations, So again, this is an ICMR initiative. I don't want to comment on that, but for surveillance purpose, it will be helpful because they are doing cluster sampling methodology and doing this pooling and all. So they are also doing ELISA test for using the antibody test also for the same methodology. So both methods are being tried. For surveillance purpose, yes, it is helpful.
Thank you. Thank you. If what's the plan? If there is any other questions from panelists?
Sir, when will we get appropriate RDTs, rapid diagnostic tests?
So $1,000,000 question. So I have to answer this because they are the focal point for like validating the kits and giving permission. So you know what happened with the kits which were imported. So there are Indian companies, they have come up with rapid diagnostic kits which have been validated and proven to be like much sensitive and specific. So they are on the pipeline, and a lot of other platforms like Cepheid, CBNAT platform is being tried. TrueNat is being tried. TrueNat platform, which is which will diagnose both TB and COVID. And the viral load machines like Roche machines, which are already available with National AIDS Control Program, they are being tried because these results you can get it like within an hour or so. You know, they are very quick. And like now, US has permission, FDA has given permission for specific antigen test also. On 12th of May, FDA clearance was given for some antigen kits. So like things are evolving and a lot of discoveries, but unless it is validated and given okay by ICMR, like we won't be in a position to use it in any of the health facility. As ICMR as a nodal agency has to give permission for that. Thank you.
Sir, can I ask a question, sir?
Please, sir.
Sir, Balan, sir.
Yeah.
There's no politics involved in this question. Our government now doing a proper work, like other countries, we see the spread and we have not got it. Some people have a complaint that we should have opened up early so that we could have had a community spread. And so many talks are going on. I just want to know, are we on the proper way of doing it? Because we have a precinct before. So what is your opinion on it, sir?
Sir, already I have answered this question, like making everybody getting the infection, which will be costing so many lives. And like lockdown was not only to prevent transmission, it was mainly for slowing down the transmission and also preparing the healthcare facilities. That was the main purpose of lockdown. Lockdown was never like, maybe it might have been interpreted by people, but it was never for stopping the infection spread. It will slow, but lockdown will never like stop the infection at all, like wholly. It will slow down and it will give time, buying time for preparing our healthcare facilities, buying equipment, making PPEs available. All those things have happened. So every country is struggling. You know, US is struggling, UK has struggled. Now they are getting better. China has struggled. Every country is struggling and they are coming out of this. Like we are not alone. So this is there in 215 countries worldwide, like not only in India. And many countries are struggling to cope up. So like again, like herd immunity you are mentioning, like getting community transmission everywhere, that will come at a cost of so many lives and so many people falling sick and without proper care. So I hope I answered your question.
And I think if you look at the places where there's been high transmission, such as Wuhan in Italy, you end up not only having mortality in the coronavirus patients, but also for patients who can't receive medical care, such as those that have heart attacks and strokes and need cancer treatments because you overwhelm your healthcare system. So it's another reason why it's really important to try and limit transmission.
Yeah, and Dan, like you can like tell more about this. US never went for a whole country lockdown. Some states did the lockdown, like in a partial lockdown was followed in some of the places based on the hotspot and things like that. But they never went for a whole country because it may vary from country to country, the culture, the population density, all those factors come into play. So when somebody is planning common, they don't plan like that. You know, they would have thought all the demerits and merits, and then like something is better than nothing. Like that's why they might have gone with the theory of social distancing and things like that.
So continuing the same question, sir.
Yes, sir. Please.
Sir, can you hear? Yeah. Continue the same question, sir. In our district, you know, Kanyakumari district is slightly a smaller district. What do you think? How many of our districts are going to get infected in this process of COVID disease in Kanyakumari disease till December, just you can, how many have any idea how many members can get infected?
Sir, we have to do some modeling projections so that we will know, based on the infectivity rate, like currently how many people are getting tested, all those things. There are projection models available for countries, but like maybe somebody from your SPM department in Kanyakumari Medical College, they can take up a projection study, modeling projection study, which will guide you to get an answer for this, because like a lot of other factors also come into play, including density of population. So you have to have a SIR model. Usually they do more in modeling studies, this SIR model, that is how many are susceptible, how many are infected, how many are recovered or died. So SIR models are used. So someone from Kanyakumari Medical College can take this up from the social and preventive medicine department, and they can work on this. So I don't have an answer, but definitely by doing projections, you will have an answer.
Dr. Valan, I have one question for you. Definitely, we'll do that study, as I am the HOD of Community Medicine at Medical College. But my point here is, India, the doubling rate as of today is 13.3. And my question is whether we are going for a imminent community transmission.
Sir, this is a political question. So, as a community medicine professor, you know the current status.
I want to ask you, still now we are not in community spread or not?
So, so Dr. Suresh Balan would be the better person to answer this question, as he knows.
Sir, I am asking it as India as a whole, sir. Not only for Kanyakumari.
No, yes, as India as a whole, also you know the answer.
Thank you.
Very intelligent answer. Thank you. I think so.
But, ICMR has taken up a study to ensure the findings that like ongoing community transmission is there or not. Like they have undertaken a study recently by doing some sort of surveillance. And like, but yeah, Dr. Suresh Balan will be the right person to tell the people from Kanyakumari district like what is happening.
Thank you, sir. Thank you very much. I think so. Like we crossed the time of like now it's like 9 o'clock. Everybody's hungry. I think so. Like we had a nice, excellent discussion on like COVID. I don't think like we left over anything. Now it's the best time to say thanks and vote of thanks, like by your friend and like Dr. Edwin from Marthandam IMA, President. Dr. Praveen, can we wind up, sir? Before that, like I'll ask the panelists, each and everyone, can we wind up? Any question before that?
So all the slides, like Dan, like, would you want to comment about the support we are planning to provide to the slides and
we'll provide some of these slides that you can distribute. I think that there's also some key resources such as that are specific to surgery that we can send, some good key articles, as well as some of the ventilation.
Dr. Daniel and Merlin, that will be very useful for us. Like, so there are like, you know, the Kanyakumari district is hub of the hospital. Like, so like each and every hospital will be utilized this whichever in the instruction or like messages you are going to give to us. This will be like given to each and every hospital by printout or like pen drive, whatever it may be. Thank you very much.
Yeah, I was just briefing to Dan about our district and hospital density. You know.
Thank you, sir. Like the seniors, Dr. Vijaykumar sir, Dr. Jailal sir, you want to convey some messages, sir?
Oh, it's well done. It's a good coverage. Thanks to Valan for
wonderful, sir. Actually, I am really happy, but even though I missed the first part, I enjoyed the discussions, and it was wonderfully done by Balan as well as Daniel, sir. Congratulations, sir. So once again, I congratulate NAGERCOIL, Marthandam, and Kanyakumari IMAs and Kanyakumari Medical College IMAs for organizing such a wonderful event. Congrats. Thank you. Sorry for because of some other occupation. Thank you.
Edwin.
Sir, good evening to all. Sir, first of all, I thank our organizer, Dr. Shivakumar sir, for organizing such a wonderful webinar for our regarding safe practice in COVID-19 pandemic situation. And I sincerely thank Dr. Shivakumar sir for his tremendous effort and to organize this nice meeting. And I thank all the participants, panelists, senior panelists, Vijay Kumar sir, Jailal sir, Professor Suresh Balan sir, Nagarajan sir, Trevi Mohan sir, Chitra madam, and I thank
Praveen sir, everybody was
there.
Dr. Kannan, Dr. Praveen sir.
Dr. Kannan sir, Dr. Praveen sir, everybody. I don't miss no one. And I am very proud to thank Dr. Valan. He is my classmate and my friend, best friend. And Dr. Daniel from Central Disease Control, the Center for Disease Control, for giving the wonderful talk regarding the COVID-19 safe practice in COVID-19 pandemic situation. And in this nice occasion, I thank one and all.
Thank you, Edwin. Before leaving, like instead of like from the Kanyakumari district IMA, we given a warm invitation to Dr. Daniel to invite our place Kanyakumari after the lockdown or like after the COVID-19.
Yes,
Dr. Daniel, like you are welcome to Kanyakumari with Valan whenever he is coming, or you can come alone like to Kanyakumari. We will be waiting to invite receive you here.
Sir, Valan is the son of soil, so for him there is no problem.
Thank you very much. I hope to take you up on that soon.
Yeah.
Thank you.
Okay, thank you, Valan.
We have travel restrictions now. Yeah, thank you so much, sir.
Thank you, Valan. Thank you.
Valan, thank you
all. Thank you.
Bye.
Bye.
Bye. Bye.
Bye.
Thank you, sir.
Thank you, ma. Thank you.
Thank you. Good night, sir.
Night.
Thank you, Shivakumar, for the excellent program. Fantastic.
Thank
ரொம்ப சிறப்பு, ரொம்ப அருமை. அதுல வந்து எட்வின் வந்து பாக்குறதுக்கு ஒரு சினிமா ஸ்டார் மாதிரி வந்துட்டு இருக்காரு. வித்தியாசமான கெட்டப்ல சூப்பரா இருக்கிறாரு. சிவா, நீங்களும் வந்து சூப்பர் ஆயிட்டீங்க. வர பாக்குறதுக்கு ஒரு சினிமா ஸ்டார் மாதிரி தான் வந்துட்டு இருக்கீங்க.
முடிவெட்ட வழி இல்லாம
Fantastic. Thank you, boss. Good night.
Thank you, sir. Thank you, sir.